Okay, good morning, everybody. My name's Mairead, and I'll be with you today on this session. So as I said, we were expecting around maybe perhaps 20 people, but it's 9 o'clock and that's when we were set to start. So if anybody joins us, we'll let them in. So you're here, I've been told, because you've been volunteering with us, or you've been working around the NHS, primary care in particular, over the last maybe few months, few years, and you'd like to know a little bit more about what we do and whether you'd like to join us, which is fabulous. We're always actually on the lookout for people who are enthusiastic. Doesn't matter about the skills or your experience, what we need are people who are committed and enthusiastic. And over the last 2 years, I have to say, I personally, I've lost people from the NHS. I don't mean that they died. I mean that they decided that they were leaving. They were leaving earlier than they should, and we have quite a few areas that have big skills gaps. So we're always on the lookout for people to fill those gaps, to take the NHS through to the next phase, the post-COVID phase, if you like. So I'll just tell you a little bit about myself. I joined the NHS in 1983. I know what you're thinking. She looks young. I know. Thank you. And I trained as a nurse. And I don't nurse anymore. I'm a manager, and I've been managing practices for 28 years. I know, long time. So we know why we're here. And I'm delighted to see you all. And I just wanted to go through the agenda for today. We're here till 4:30. We can have fewer breaks, or we can have longer breaks. It's completely your day and completely up to you how you would like to, how the day will roll. But this is the agenda that I've been given, and this is the agenda I'll be talking to. But of course, at any stage, stop. We can discuss anything that you'd like to discuss. So we have to start off with the basics, founding principles, the ethos of the NHS structure, roles and responsibilities coming into the new world. Okay? We still have to do the things we have been doing, but we have to do things differently, and there's more of it to do, and we'll go through that. Obviously, we have to respond to the patient's needs in its entirety. Up to the roles and responsibilities of our job. So we never step inside or outside of the roles and the responsibilities that have been designated to us. We aren't clinicians, and so we work up to safely, because we've been trained. We're going to be working up to our roles and responsibilities, and that's how we keep the patient safe. We have to look at information governance. Was it Pete who's in IT? Jump in at any time, Pete. Help me out. It's probably when I get sort of most, I don't know, I won't say disinterest, I think. Lots of people go, information governance, blah, blah. But because we are managing patients' data, we're managing personal data, it's got to be at the forefront of everything we do. We'll look at the monitoring process, who's monitoring the primary care. We'll look at patient participation. Unfortunately, we'll have to take a little look at the complaints. And in the afternoon, the very last thing we'll do, hopefully it'll be a little bit of fun, we'll look at communication skills. You'll see when I show you the statistics on complaints, it's obviously logical to expect that if we have increased the amount of contact we have with patients, then of course there will be an increase in complaints, and we'll see how those are broken down and how we can redress the complaints that are coming in. Please enjoy yourself this morning. Please get involved. If you're not speaking, then if you could unmute, because there's always a little bit of background. And this is a safe space. We are here to not attack, but we're here because we're interested. You know, so we should be able to speak freely about every issue that you want to speak about. And this is one of the slides I put in, and I do it on every single occasion that I train delegates, because it's been a hard slog over the last 2 years. Sorry, somebody said that they were working in a hospice. It has its highs and lows, doesn't it? Well, the last 2 years has been huge amounts of high and low for lots of us. I used to work on paediatric oncology when I was nursing, and I realised I couldn't. That wasn't for me. And after today, you might feel that you don't wish to pursue any type of career in or work in the NHS because it doesn't suit everybody. However the day pans out for you, what I'd like to remind us all is that ships don't sink because of the water around them. Ships sink because of the water that gets in them. We have to have inner resilience, especially when we're in the NHS, especially, you know, on the oncology ward, paediatric oncology. I said to one of the staff nurses, I mean, this is years ago, but this is where I learned about inner resilience. We had 2 deaths in 1 week, which was exceptional, really, and it was very devastating for everybody involved. The staff nurse, we had a brief moment, and then she gathered her thoughts and she went out and she proceeded to do her job. And I was absolutely in awe of her. And I said, how can you do that? She said, because I have to. Because if I take the grief and the sorrow and the pain and here with me to the next patient, that's not fair. I have to park it, right? I have to reset, because my job as a professional is to help that patient. You know, and it's as sad as it is, I have to move through it for the next patient. And I didn't know the terms inner resilience. I didn't know anything about, you know, ship sinking, mindfulness. None of those terms were around back in the day, but it's really stuck with me, and I'm going to I'm sharing that with you now. Okay, so history. Let's start from the very start. So the history before the NHS, some of you will know, I'm sure, that we didn't have the NHS. It hasn't been around forever. What we had were workhouses. Lloyd George, who was the Minister for Health, enacted the National Insurance Act, which I suppose was the sort of starting point for the NHS. The NHS proper was launched after World War II. I beg your pardon, and it was set up by a Labour government, 1948. So I'm going to shout out, if I said to you, who is the father of the NHS? Who would it be? Anybody?
Nye Bevan.
Nye Bevan. Nye Bevan. He left amazing man, and he had so much foresight and vision. He left school at 13, which I find astonishing. But yeah, father of the NHS, Nye Bevan. You'll see lots of buildings around within the NHS named after him, and why not? Why not? So when he set up in 1948, the NHS, along with the Labour government of the time, they had 4 founding principles. That's where they started. They started from these 4 principles. Anybody know one or all 4?
Free at the point of use.
Yeah, absolutely. Anyone? You know it.
Universal. I can't remember, I'm not sure how I'd say that.
Absolutely. Universal access. So cradle to grave, you are born and you die, and the NHS is going to look after you. Right? That's one of the founding principles. Free at the point of delivery. No money exchanging hands. Okay? Based on need. Now, there's a lot of controversy about this because there is a difference between a need and a want. Okay, so we'll go through that later. That's where a lot of the conflict comes in between patients and NHS staff, based on need. And then a bit like the National Insurance Act, it is funded by general taxation. Okay? So we have taken those 4 principles from 1948 and we have expanded them into these more comprehensive principles. So we have gone on to say that, you know, even if you don't pay taxes, you know, we don't exclude children, we don't exclude non-taxpayers, you know, prisoners. I'm thinking of people who don't pay tax, you know, people who don't earn a huge amount, people who have no income. So it's not based on any tax. You do not have to pay into it to receive care. The next principle, we need to up our game, aspire to the highest standard, basic core principle. We have to reflect the needs and preferences of the users. The users are us. Yeah? They're our patients and our families. They are us. So it has to be reflective. It has to respond. Now, I know that's not, it doesn't always feel like it's doing that, but it is a core principle. Got to have best value for taxpayers' money. Anybody know one of the organisations that is very much in the news regarding what we can and cannot prescribe within the NHS? Does anybody know that organisation? It has an acronym, a nice acronym. In fact, it's NICE. And anybody have heard of NICE? NICE? National Institute.
Yeah.
Yes, Clinical Excellence. Yes, you'll have heard it. And that's the organisation that is getting its remit is to look at everything that's out there that's new, being used, new diagnostics, new drugs, treatments mainly, and it looks at it and it says, is this value for money? Okay, and it's sometimes we know it says no, it isn't. And we know that. And of course, accountable to the public. It's a nationally government-funded institution that has to be accountable. So let's have a few facts and figures. It is enormous, the NHS, absolutely enormous. It used to have a mere 1.4 million workers in 2017. It is now 1.7 million workers. You know, not all part-time, not all full-time, part-time workers. You know, this is the whole gamut from, you know, the top consultants, the great professors, all the way into the, you know, the people who, you know, clean and cook our meals when we're in hospital. It is enormous. It is the 5th largest workforce in the world. Anybody want to hazard a guess? BT, I think, used to be on a par, but obviously it's been chopped up and broken, you know, into different units. But anybody want to hazard a guess about what's number 3 and 4 of the biggest employers in the world? Anybody want to hazard a guess who they might be? If I said there's golden arches, McDonald's. Can you believe it? Can you believe it? Although not in Russia because they've closed, haven't they? So that's going to reduce the numbers. And number 3 is Walmart. Okay? And I think the first 2, I actually think they are people who work for the American government, the state, and people who work for the Russian state. So it's those, and the NHS is number 5. So it is a massive organisation. And that it does feel like that sometimes. And unfortunately, it means that, you know, the service user is, the institution is so enormous that we forget sometimes to focus on the job. We're dealing with all the politics up here, and we forget to keep our focus on what our core principles are sometimes, in my opinion. So let's have a look see where the people who work in the organisation are. So this shows you, the block shows you the size of the people. You can see HCHS, those are hospital doctors and consultants. And all of the things in blue are the organisations outside of primary care. The purple on the right-hand side, it's purple on mine, it's perhaps a different shade of blue with you. That shows the primary care staff. You can see it's just a sliver, this is from the Nuffield Trust, so it's good information. I can vouch for it. So 85,000 non-clinical staff work supporting the clinical staff in primary care. We have 35,000 plus GPs and 16,000 nurses. So I'm going to ask, anybody come across the 80-20 ratio? So you can see from the slide, from the presentation, there we are, that sliver down the side there, the sliver down the side. So as far as funding goes, when you look at the NHS as a whole, it's the 80-20 ratio. 80% of all consultations, by that I mean between a clinician and a patient, 80% of that contact takes place in general practice. Okay? Takes place in general practice. And of course it does, because if you look at the statistics, and it's always been on between 93 and 95% of the population is registered with a GP. Practically everybody's registered with a GP. There's two sections of society that aren't registered with GPs. Anybody want to hazard a guess about who they are? Tragically, the most vulnerable patients are most vulnerable. Those who are living what you'd call just outside of society. The homeless, people who work in the sex industry, asylum seekers, refugees, people who really are in the most need. They are not generally. They struggle to access services, which is a great shame. And then the other side, it's the top and the bottom of society, really. The super rich, they don't need us at all, do they? So there we go. Nearly everybody's registered with a GP. However, not everybody needs to go to hospital. Not everybody needs other services. But everybody needs us. 80-20. So 80% of the work, not the work, but 80% of consultations is carried out within general practice, but we get 20% of the income. Of course we do. We don't have big hospitals to run. We don't have huge diagnostic machines and all these professors, and so yeah, but we do feel, when you've been around as long as I have in the NHS, you do feel very aggrieved sometimes about where the pot of money goes. So primary care especially, you can see I'm hoping you can all see my arrow there. Yeah. What do you think's happened to primary care over the last, just since 2019? Anybody know what's been happening in the world of primary care? Sorry if it's shaking around a little. The number of GP practices in England in 2019 had fallen 18% to what it was in 2004. Any why would you?
Because they got bigger, or they joined together and became bigger practices and less single doctors and things?
Absolutely. We have gone from a model that had small surgeries dotted around the place to, because the new world is with us, we are looking at economies of scale. So we are coming together because, why reinvent the wheel here and there and everywhere? Let's come together and have one, more economies of scale, more systems that align with each other. And one of the big things, of course, you'll have come across this, the postcode lottery. Okay. So the care and attention that I get in my area could be different to the care and attention you get in a different area. And that differences can be geographically really close. So on this street, you get this care. On the street down the road at a different practice, you get a different set of care. And what we've tried to do is it's been happening for years, bring general practice, primary care, out from the old tradition of, Nye Bevan, God love him, he tried his best, but he could not. There was not enough money in the NHS coffers to salary all the GPs. One of the big reasons for that. All hospital doctors are salaried, unless they're locums, but GPs are independent practitioners. Okay, so that again, the structure of the NHS is quite complex, and that in itself has got its having a non-salaried contracted general practice brings with it lots of positives, and don't think there aren't, because there really are lots of positives. But there is also some negatives involved in there because they're independent. But the model is to move to larger practices covering greater geographical areas. Yeah. Nye Bevan couldn't get general practices salaried because most of the GPs, in fact, all of the GPs practiced from their own premises. Which is why when you look around, 2 of the last surgeries I've worked in, they're houses, they're homes. They have been, redeveloped so that we can run a GP practice from them. But that's why there's so many. Two of my friends from America came when I was showing them the surgeries that I'd worked in, and they were like, "Gee, how can this be? This is a house." I said, "I know. That's the way it goes." So we're trying to move away from that as well. And one of the reasons why we have to move away from some of the premises that we have, they're not fit for purpose, are they? They're not accessible. There's loads of stairs. The rooms aren't big enough. So, that's the reason why. It isn't all, the statistics are statistics, and you can read them into them in any, in any way you like. But the reality is that GP practices are coming together. They're coming together under what we call the PCN networks, but they're also amalgamating together. Okay, any questions? So, as I said before, the only thing I know about the NHS is that it changes. Many times I'm, as a manager, I'm setting and geared up to go down this route, and I've got everybody in place, and then, oh, no, shelve that. No, we're off this way. Oh, okay. So I have to go that way. Change. That's the one constant. And let me tell you something else. Things, when you've been around as long as I have, things come round again. You're like, oh, I'm sure I've seen that film. And why not? That's what we are. We reinvent the wheel, and you get some great gung-ho youngsters in, and they go, I can sort that out. And I go, absolutely. I will be right behind you. So, change. change. This is the NHS structure at this current time. And for our purposes, I'm going to try and keep it simple, because again, we can get bogged down. It's quite nitty gritty. So this, on the left hand side, we have the blocks, and it says commissioners, and then you see the big pound sign, and then you've got providers. Okay, so we have a commissioner and provider split. So the commissioners are our clinical CCGs, our clinical commissioning groups, NHS England, that's at the top, but generally, because we're primary care, we're being commissioned by the local CCGs. Then we've got local authorities, because the 2012 Social Care Act is we are trying to implement it. And at the bottom there, you've got Greater Manchester devolution. Now, Manchester, as far as I know, and I could be wrong, is the only area, it's the only borough that has amalgamated its primary care, its health care with social care, which is why it sits there as its own particular block. It's gone the whole hog, which is really interesting, and I'll be fascinated to see how it all pans out. So what we have there is that this group, they commission services. Look at the provider group. It's quite busy. It's quite busy. Years ago, that provider group, the commissioning group was the NHS and local authorities. The providers were GPs, okay, and some voluntary sectors. But basically, it was just us. Now, take a look. We have private providers. We've got the voluntary sector that has funding attached to it, and will actually have funding. We've got GPs. We've got pharmacists. We've got trusts, secondary care trusts, getting in on the Primary Care Act, you know, and then we've got this new system called accountable care systems. We'll go through that in a little while. So this is where we are. And remember that GPs and clinicians who work in primary care also sit as commissioners. So there's quite a complex little, and at the very start of this new structure, there was a huge amount of controversy about this GP provider split. You know, GPs were told there were too many legs. A leg in both camp wasn't good. However, that's settled down now. So I'm sorry, I don't want to bog you down into the structure, but it's worth understanding where we sit. This is the clinical commissioning groups. They remit, they have a mission, just like the core principles of the NHS. It's a mission statement: achieve excellence in health and well-being in partnership with the local population, never forgetting the people that that service users that we're trying to help and get better health outcomes for. And don't forget, I talked about the Social Care Act. See the last box. We're trying to flatten out, if you like, instead of a hierarchy of where decisions are made outside of the service users' prowess, influence. We're trying to bring it back into a more patient-facing service. Okay, still not quite there yet. And then, of course, we have to hit on what is a GP federation. So we got the NHS England, NHS Improvement. We have our local commissioners. Then we have all of our providers. The way it's set up is that the GPs don't get paid directly for any local work that's been commissioned through this system. They get paid, the federation gets paid, and the federation spreads the money around to where it should go. It's a little bit, I suppose because I work in it every day, I can see how everything fits, and I don't expect any of you, unless you have good working knowledge, to grasp it immediately. But basically, every GP practice must be in a PCN, primary care network, a local network. Every GP has to be part of a PCN, and that's what I'm talking about, economies of scale. We are looking at much more trying to throw out that postcode lottery. Okay, so this is this integrated community services, integrated with social care and healthcare and primary care. And this is the vision we're trying to get to. And of course, as you move forward, things don't always work, and you have to take a step back. There's certainly COVID knocked quite a lot of this vision and work sideways. But we are coming back. We are coming back to trying to develop this more, kick out that postcode lottery, have higher standards across areas that meet the needs of the patient. That's our vision. What is primary care? I'm so sorry. I was at book club last night. I think there was a lot of talking and I'm a little bit hoarse now. Good book, by the way. I'll let you know if you want to read it. Primary care. Primary care services provide the first point of contact. Okay? The first point of contact. Okay, and it includes obviously general practice, we do the bulk of it, community pharmacy, very big at the moment, dental. We know there's some controversy about NHS dental care, and optometry with a first point of contact. The GPs have a special place because unlike the optometrists and the dentists and the pharmacists, we are charged with looking and focusing on the health of the whole person. That doesn't happen when you go to hospital, right? You go to a gastroenterologist, that's what he's going to, well, she's going to look at. She's going to look at your gastroenteric system. She isn't going to look at the psychology. She isn't going to treat you for any mental illness. Okay, this is the exceptional place general practice has. And the other thing, you know, I'll just say it in case I forget, this is the cradle to grave. Big pharmaceuticals out there want to grab information from us. They want to get in. We know, I was there. Actually, I had the afternoon off, which was so great. You know, we got hacked. 2017, we got hacked big time. NHS emails went down. Our systems, our medical systems went down. And it went down one Friday afternoon for about 6 hours. Chaos. We have exceptional, unprecedented medical history sitting in our medical systems, which is why information governance is so important, because it's cradle to grave. No other country has it to the extent we have it. And if you can imagine just how valuable that information is, you know, a patient's medical history from cradle to grave, all the drugs they've had, the ones that worked, the ones that didn't work, the outcomes. Massive, important information. But this is why we are exceptional. We are cradle to grave, the whole person. We have practically 100% of the population registered with us, and we have to have a holistic approach. We are what's termed the waistband of the NHS. Okay? If you think that the top bar, the patient population, if you want to get into that holy grail of secondary care, if you want to get into those specialists and those consultants, because they are really focused on that one thing or two things, you cannot, unless you're super rich, you can't access that unless you go through the waistband, which is us, GP, primary care. You have to be referred. So how else, what other method is there if you're a patient to get into secondary care? What other method? What if you're not going to go through the GP practice? What other methods are there? What's the route? I beg your pardon, sorry.
Could you go through?
You could go. I'm so sorry. I can't hear exactly what you're saying. Sorry.
Oh, could you go through A&E?
A&E. Okay, so you can go in as an emergency, right? And that's it. They'll treat you. They'll stick you in the system, but it's back to the GP. Or you're very rich and you can go privately. That's it. Those are your two options, right? You can either bypass the GP in an ambulance, or you come to the GP. And this is where the conflict arises. You know, remember what's happened in the last 2 years since, you know, GP practice has become a holding cell. And of course we do. That's what we're there for. Secondary care closed its doors. So all of those people, all of those patients that we'd seen, that we decided that our expertise stopped. We didn't know, we've tried to treat the patient. No, okay, my expertise as a general practitioner has stopped. It's ended. I need to refer to a specialist. So all of those patients that needed specialist treatment, back to the GP. And of course they had to come back to us because there was nowhere else to go. Secondary care was doing that job that it did brilliantly of looking after all of those people with COVID and their families. They had to close their doors. And that's, I try and keep always an open mind. Patients are frustrated with the system. They're not necessarily frustrated with us as individuals when we're working in practice, but they have nowhere else to take their frustrations out in. They can't walk into secondary care and start shouting, demanding things or crying. I mean, they can, but they do behave in those ways when they come to us because they need what they want and need, they believe they're not getting. So we have to remember what's happened and our place in what's happened. So yeah. So what do GPs do? Well, again, I've seen many contracts. I was around for fund holding. I was around for the new 1997. Gosh, that sounds old. They introduced the internal market, so that laid the groundings for the commissioning and provider split. But 2003, this was a tremendously controversial contract. It took 2 years of negotiation, but basically it told GPs, because they're contracted, they are not salaried. Yeah, there's no job description from the NHS. It is a contract to provide services, and it was laid out specifically in the 2003 contract. Okay, before that, GP did what a GP did. Postcode lottery. What this GP did and felt that they should do in this practice was different to what this GP felt that they needed to do in this practice. Right? So remember, we're trying to level the playing field, and this was one of the ways, and why not? No other better way to do it. And this contract changes every single year. So some things last year that were, of course it does, it has to. We've got COVID. That's not been in anybody's contract. Monkeypox. That's the latest one. What are we doing about that? So the contract lays out extremely explicitly what the GP is meant to do. However, we know things change. The world changes. So not everything can be in the contract. So when we are coming to try and meet the needs of our population, we have to have something else other than the contract to enact that. And this is where we have what's called local, nationally commissioned extra enhanced services and locally commissioned extra services. So we have a national enhanced service to try and tackle obesity, and let me tell you, that is it's up there with smoking. It's that risky. It is that fundamentally bad for us. And we have, like the pandemic, we have a pandemic of obesity across the world, certainly, but we have an epidemic in the UK. So the NHS is asking GPs through a different specification to manage and treat the obesity crisis. And then we have things that they're only very local to your area or to one's area. Of course, the GP contract says we must provide childhood immunisations. Of course we must. No one's debating that. But in some areas, the uptake of immunisations is really poor. So the commissioners will commission a local enhanced service to meet that need. Okay? So this is the contract changing every year. Anybody, any questions? Are we good? Great. Please don't keep anything. Let it out. Talk to me. So who's in the primary care team? This is where we're coming to the nitty gritty. Well, pre-2019, we had, the usual suspects: GPs, nurses, nurse prescribers. Now, there's a little bit, the nursing fraternity can get quite itchy and scratchy about this. Nurse practitioners. I mean, a nurse can call themselves a nurse practitioner, but basically, nurse practitioners really need to be nurse prescribers. That gives them a more independence. They are able, because they've been trained and they have a prescriber's code, to treat patients. It's a step above your usual nurse. Of course, we have the healthcare assistants and the reception administrators. That was, basically who was in the team. From 2019, from 2016, we've been trying to push through these new ways of working, right? And what we have now, because of COVID, this new way of working really took on speed, right? That it was, but GPs, independent contractors, quite ploddy about some of the new things that were going on. COVID came in, changed the scene completely. We now have in-house pharmacy, as we call it, in-practice pharmacy. So there are pharmacists who work in our teams now, not out there in the community, in our teams. We also have the new community pharmacy referral scheme, which means that we are to signpost patients from the practice to the local pharmacists, and they're all prescribers, so they can help. Right? We have social prescribing and link workers. Where was it? One of us in the team there, was it Nasifa? It gave us a great description of the jobs that link workers do. We would have been on our knees without them during COVID. The physician's associate, those are people, some of whom, like yourself, will have first degrees in clinical science subjects, who want to take it further. A little bit like the nurse prescribers, they will be seeing patients independently and advising. Physiotherapist, crikey O'Reilly. The waits for physios was just, it's still a wait, but now we have physios working in our teams. Brilliant. Counsellors, we have them working for our patients in our teams. And at the bottom there, in bold, because this is my, this is my bag, we have care coordinators, care navigators, we have got GP assistants, and we have prescription clerks. All of those things, all of those titles are where non-clinicians, people without any degrees in science or biology or any of those things, they're people who have been working in GP practices or who are new to primary care, who are being developed into taking the roles that GPs used to do. Some of the duties, they're taking them from the GP and they're carrying them out themselves. Okay, so that's absolutely pretty good. Good for general practice, good for patients. I know you may not feel that, but it absolutely is, and we'll explore that. So we are coming into the new order. We are bringing in health coaches. You know that phrase, you can take a horse to water, but you can't make it drink? Okay. This is what's happening. The amount of DNAs pre-COVID was astronomical. Patients would come to us because they felt they needed help and assistance. We'd refer, they wouldn't turn up. How many times do we know, maybe in our own families, people who need help, they know they do, but until they decide to seek help for addiction, for gambling, for alcohol, until you decide to give up smoking, no amount of someone saying you should give up smoking, it's good for you, no amount of that's going to help. It's not going to make you change. Health coaches, dietitians, podiatrists, and you name it, others. You might have all of these people now working in our practices. Absolute far cry. Why do we need all of these extra people? I'm just going to go back a slide. They're called, I have to be really careful when I say this, they're called ARPSs. Grow up, Braid, yes. They're called Associate Reimbursable Roles Schemes. Yeah. So why do we need all of these new people working for us.
Take impact factors to free them up, do other.
Absolutely, absolutely. We've got these highly trained clinicians who've done 7-10 years training, and then and they're looking at paperwork, and they're looking at patients and saying, honestly, you need a physio, thanks for coming to see me, but you need a specialist. And if we can take away the things safely and signpost to other professionals, we're not just saying go away, we're saying we've listened to you, we understand, but we're going to take you, we're going to ask somebody else to help you. It's called releasing time to care. We've got an ever-growing older population with multiple comorbidities. They won't just have arthritis, they'll have diabetes, they'll have unstable diabetes, they could be smokers and have poor breathing and COPD, chronic obstructive pulmonary disease. People as we get older don't have one thing, we've got 6 things. Multiple comorbidities. The whole person has to be looked after. And this is why, look, 2016, this is the King's Fund are telling the NHS, the NHS is really under pressure, general practice in particular. 2019, even though we had all of this new innovation and development going ahead, 2019, I'm sure you know who Robert Peston is. Robert Peston tweeted this. The gateway, the waistband of the NHS is shut. I can't tell you. I mean, I can remember him posting this. It caused such a stink. And we come to, the middle of COVID. GP practices are at breaking point, a 20% surge. Of course, we know why. Primary care is closed. The amount of anxiety, the amount of isolation, worry, sickness. This exploded. But the great thing about GPs, and I told you there are lots of positives about it being independent contractors, we turned things around. We responded to the extent where now, look, February 2021, we were at bursting point. We didn't think we could take any more. But look at us, February 2020, a year later, 2 million more appointments per month. Okay. So we are adapting. We are adapting to our local population needs. We pat on the back, right? I know when you work in general practice, it doesn't always feel, it feels that we are sometimes drowning, we're letting the water in, but we need to stand back and say, actually, we're doing okay. We can do better, but we're doing okay. What the ways to help the general practice get a handle on this new way of working came about, and it's called the General Practice Forward View. Okay, it's been around since the research that was laid on the table was done in 2015. 2016 is what this is what they came out with. Absolute increased new technologies, upskill the workforce. They finally got it. There's people in general practice that could be doing more things safely so long as they're trained, right? And they came up with all of these frameworks. And for those of us who aren't in the clinical field, one of the most important things is that one in colour, which is called the Care Navigation Competency Framework. And that is number 1 of the 10 high impact action points. I'll say that again. It's number 1 on the 10 high impact action points. Look at them here. This is the innovation that I was talking about, that COVID absolutely, we sucked it in. Number 1, active signposting. Social prescribers came into their fore here. Local pharmacists came into their fore here. Active signposting. Not everybody needs to see a GP. It's the diamond, right? The patient phones up and says, I'd like to see a doctor. And if we don't signpost, people like me at the front desk, because I'm rotated to do every single back office job, and I've done every back office job that non-clinicians do. People like me say, if we don't say, oh, can I just ask a little bit more about why you'd like to see the doctor, then the patient will get an appointment with the doctor. There could be, because it's routine, it's not urgent, it could be a week's wait. The patient waits a week and sees the GP. The GP says, oh yeah, 10 minutes consultation. Oh yeah, right, you need to see the physio, I'll refer you. Okay. The physio, there's a 3-week wait for the physio. So with some with upskilling, we can coach the patient. You know, we can help the patient. Okay, it's only not getting to the most appropriate person. It's only taking out a week, but at least it's taking out a week. So instead of the patient waiting 4 weeks and having 2 appointments, the patient has 1 appointment and receives care from the most appropriate clinician at the earliest opportunity. Active signposting. No nurses do this. No doctors do this. I mean, they call it referring. It's frontline staff, the first point of contact. Okay, and this is about upskilling. New consultation types. COVID came, out came the laptops. Pre-COVID, it was difficult for me. I was finding it difficult to get at least 2 of my GPs in one of my practices to even consider telephone consultation. They wanted to see the whites of the patient's eyes. Thank you very much, Mairead. You're not a clinician. You do not understand. Well, look at us now. Those same GPs, triage. The same GPs are doing remote consultations as a default. Controversy again about that with some patients. Okay. So this is the 10 high impact action points, and you can see reducing DNAs. Well, we're still working on that sometimes. Developing the team, partnership, PCN, pooling back office resources, social prescribing, link working, supporting self-care, health coaching. Here it is, all laid out. And the theory behind it was the research I told you about. They did it in Brighton and Hove, and they said this is even the most risk averse of the GPs said at least 26% of the patients that they see could be directed elsewhere safely. That's the most risk averse. I mean, so when I do active signposting training and I say to the delegates, you know, the staff, what percentage of consultations with the GPs could be signposted? What do you think? This is the most risk averse, remember? What would you say? Just off the top of your heads, what would you? What percentage of the patients that come and see a GP could have been seen safely by a different person?
I'd say about 40%.
At least 26.
40%, 20%. Interesting. Any offers?
I'd say about 50%, 60%.
Oh, right. You see, that's absolutely, Steffi, because when I talk to frontline members of the teams, they will say, flaming hell, 50, 60, maybe 70. Because that when you're taking it from the patients every single day, you know that your heart bleeds when you have no more appointments. And then, of course, you know, the GPs will say, well, that patient really could have been signposted somewhere else. So, yeah, it is interesting who you ask. And that figure, when the GPs asked, remember, 26%, the most risk averse, you ask those same GPs and they'll say, oh, yeah, 50%, something like that. So there we go. We are moving this. We've had this enormous explosion. We didn't know what we were doing. We settled quickly, though. We responded, we reacted, we put the new technology in, we brought in outside arses, we brought in outside workers, we're developing our team to take on new roles. We're coming out the other end and we have to settle. We're still settling. I don't know where it's going to settle, but it is going to settle. There is no way back that way. Now, we have all opened our doors. That's number one. However, I'll show you some statistics to show you just how much things have changed. So, right, we've got the point. There is, 2,000 freed up appointments. Time to care. Remember, it's releasing time for GPs to care. So this is very much part of the developing, emerging new world, that the patients aren't really, in my opinion, they haven't been really encouraged or have this explained to them. Again, I talk about conflict. There is controversy about this. Patients, how many times have I been told, you are just a, get out of my way. You're just a receptionist. I want the doctor. I don't want to talk to you. Right? Well, unless we train our frontline staff in coaching, health coaching, you're going to have somebody who's never been encouraged to develop communication skills. I know that. Been around a long time. Okay, so this is NHS England. This is NHS England. This is them saying that it is the receptionist's job, not book everyone with a GP. They can only do that if they've done red flag triage training. Right? That's we have the PCNs, the CCGs, all of these echelons above us. They need to have a full directory of services. That's what the new roles are all about, and so that people like me can signpost safely. So I'm not taking someone away from a GP to a unit that isn't appropriate. We have to have all of that knowledge. Okay, remember, it's number one on the GP Forward View 10 high impact action points. The process is about getting the patient, not shoving them away, which is how people feel, and I know that. It's about getting to the most appropriate caregiver. Okay, we have to work on that, and my opinion is that's not, we aren't explaining that. I don't know, please share. I don't know how you feel about it, but my impression is that this is all laid down at the feet of frontline staff, and they're not trained. That would be my summation. And the other thing is that, again, we talk about conflict. When frontline staff who aren't trained are asked to do this, there is a lot of conflict, and they feel, why bother? Why bother? I'm going to be complained about, so I'll just put them in with the doctor. Yeah, it's an ever decreasing circle, really. Okay, this is what people say. This is what my delegates say, and you might be feeling this too. Of course, increased workload. If you're going to extend your 5-minute conversation to 10, 15 minutes, yeah, there's a whole load of calls coming through. Those calls aren't going away. Your workload will increase. When they have managers, I always tell them it will take time. Eventually, it will settle, because we'll be signposting patients and they'll understand that they're going to be signposted. But there isn't enough time. Responsibility. Again, I've talked about moving out of that, behind the desk appointment. You want an appointment? Yeah, sit down. Thanks very much. Yeah, we're moving away from that into those roles that have been done traditionally by GPs. But if we are trained, if we have our protocols, and if we only ever work up to our responsibility level, okay, it'll be safe. Yes, we might make mistakes. Yes. That's another one. Support. So the management team, the partnerships, the managers, great idea. Let's do it. And then walk away. Has to be supported. Everybody has to do it. We've talked about training. Surely this is a GP's job. Yeah. Well, paramount to everything we do has got to have patient safety at its heart. And the reason for that is vicarious liability. Anybody know the term vicarious liability? Now, this is the thing that I go, I always go to the partners. Have you heard of vicarious liability? And I'm always shocked, even after my 28 years as a manager, how little GPs have invested, not now, but had invested in training their frontline staff, their non-clinical staff. You know, we're asking people who do not understand medical terminology to work in a medical environment. It's a different language, no training, they'll pick it up. Okay? Vicarious liability. Even though I believe my teams are professional, they try and do a professional job, we aren't actually classed as professionals because we're not in an institution that can kick us out if we breach the rules. Right, so the General Medical Council, a GP is found in breach, it can suspend their license to practice. They can't practice. The same with the NMC, National Nursing Midwifery Council. If a nurse breaches a code of conduct, they can be removed and cannot practice. I don't know, if I do something wrong, I can get the sack and walk out and go to another practice and say, hi, I'm a practice manager, can I have a job, please? Nothing will stop me. So the vicarious liability is every single thing, every word I take, every move I make, that's a Sting song, everything I do, every action, every word, every comment, every entry into a medical record that I take as a non-clinician, the GPs are liable under vicarious liability. Patient is not going to sue me. Why bother? It's going to sue or take a claim against the partnership. Okay, so that's why we really have to have training, as much training as we can possibly give our staff, which is coming. And the other thing that we need to focus on is CQC, Care Quality Commission. It has 5 Chloes, as we call them, 5 key lines of inquiry. The first one, is it safe? Is your practice and everybody who works in it safe? So when we had our CQC visit, they're not really doing them now, it's virtual. They haven't got the time, they haven't got the staff, and they don't want to come into practices, which is a bit of a blessing. The CQC took one of my admin managers, said, Sandra, please come, let's have a little chat. And I was having a heart attack. I don't know why, she's brilliant. And they asked her one question. How do you keep your patients safe? So if you were frontline staff and you were asked that question, what would you respond? How just off the top of your head, what do you think would be the response they're looking for?
Would it be something?
Yeah, Sarah.
Yeah. Would it be something around training? I've been trained. Everybody needs to be trained in the practice, I would have thought.
So her response was a fabulous response. She said, I triage. I ask the patient what's the matter with them. Simple as that. I asked the patient, how can I help you? And they said, what do you do? And they gave us scenarios, and she said exactly, Sarah, she said, and it's absolutely true, the GP clinical lead did training in triage every single year for the staff. Keep the patient safe. Red flag triage. You cannot signpost a patient away from the practice that needs us. And even when we've ascertained that we're going to have the patient, this is for us, we have to triage. If it's clinical, it needs to be triaged. We know the concept of triage. Yeah, everybody knows the concept of triage. But the best examples are sadly major incidents. So you'll have 3 teams that will come out. All the paramedics and the consultants from hospitals, especially A&E, thoracics, they'll all come out and they'll have their role is to stand in the site of the event, the incident, and they go around and they aren't necessarily looking at treating patients, they're looking at triaging them. Yeah, I mean, this is a very basic example. They'll have 3 cards. A black card, a red card, and a green card. And they will label the people who they see in that major instance. They'll label them black card, red card, green card. What do you think they stand for? What do you think the green card stands for?
Walking wounded.
Absolutely. Doesn't need, triaged is not urgent. The red card, emergency. We can save this one.
Black card, death.
Don't waste your time. Isn't that's barbaric? It sounds barbaric, but that is the reality. That's the reality, and that's triage. And that's a major incident. We have to do it within primary care. Have to. You go into a pharmacist, and you say, "Can you have a look at this, please?" And they go, "Right, you need to go to A&E." Triage, or I've got a bit of cream for that. It's, it sounds dramatic. I'm being dramatic to make the point, but that's what we're doing. And we're asking non-clinicians. We're asking people who haven't been trained in communication skills or coaching or even medical terminology to do this. Right? Okay. So we have to train them. And we train them by starting with red flag triage training. Then we do communication skills training so that they can take swift and appropriate action. Yeah. And this is what it looks like. This is what reception non-clinical triage looks like. These are the protocols. This is the element where I say we work up to our roles and responsibilities because we follow the protocol. And these, you might see these in CQC when they used to visit. We used to love to see these up in front of the staff as they were taking calls or at front desk. That's the full shebang. But we have to have a separate one. I beg your pardon. Okay, sorry, I thought somebody asked a question there. So we have to have one specifically for chest pain. Because that's an A&E, that's a don't come to the practice. Those moments are valuable. The frontline staff do this. Yeah, I have done this. Somebody phoned up, had angina, crushing chest pain. Wanted his GTN, glycerin, trinitrate. You stick it under the tongue, and it was meant to ease pain. No. This man was unable to speak to me, and he didn't want to go to hospital. But I said, I'm sorry, you have to go to hospital. And he did. He was having a heart attack. There we go. And of course, COVID. Nobody come to the practice if you've got any of these symptoms. Thank you very much. And we have sepsis. Sepsis training is mandatory. Okay? Red flag triage is mandatory. It is mandated for us to do it. Sepsis. I have seen somebody with sepsis. There was a terrible case. Terrible. I sit on the GP resolution board. It's where we look at complaints, NHS complaints. And there was a case, and it was heartbreaking. A young woman. She was a very young mother, a teenager, 19, and she'd had a baby, and baby was 3 weeks old. She wasn't English wasn't her first language. It's the pre-COVID. She came in saying her baby wasn't well, and there were no appointments. She just walked in. She didn't understand the system. Why would she? And the receptionist said, "Okay, I'll get you seen. It's a little baby. I'll get you seen." They sat down. She sat down. Bit of a wait. Emergency surgery. Right. The baby wasn't crying, and the baby died of sepsis in the waiting room. Absolutely terrible. So that is why patient safety first. What had gone wrong in that scenario? Because there's a big investigation. There was a big investigation. A newborn death in a doctor's surgery. It's not like, it's happened to me. It's happened to a lot of stories. A patient came to the surgery with chest pain, did not phone up beforehand, had not been triaged, got to my door and had a heart attack and died outside of the door at the surgery. That's different to the baby. So you drill down into this. You drill down into this scenario, which I was asked to do, which is horrific. And the most junior member of the team, it's all laid at their feet. She did absolutely nothing wrong because she hadn't been trained in sepsis. So, on that happy note, why don't we have a cup of tea, I think? What do you reckon? I said I'd allow you tea breaks, coffee breaks. So that's the first hurdle over, I think. And anybody, any questions at all, apart from what cream do you use? You look so young. Keep saying that because you know, every time I say it, I go, flaming hell, 1983, a young, fresh nurse, there I was, and now it's 2022. Sound like my mother. Where did the time go? Somebody told me the other day, Mairead, you've got a story for everything. I said, I know, because I've been around so long. Yeah. So, good people, why don't we have a 15-minute break?
Okay.
If that's okay with you?
Yeah.
And I call this the wee and tea time. So that's what we'll do. So we'll come back at 1:45. How about that? I'm going to ask, I'll just put it out there. So when we talked about the ARRS roles, you saw quite a few there. Has anybody an idea already of which of those roles you'd like to do? I mean, bearing in mind some of them, you have to have a first degree in a science. Yeah, I mean, my remit was to give you an overview of primary care and certainly the new developments. But because those are quite specialist groups, I give you the view from a practice manager looking from the admin support side. So I was just wondering if any of you need, you know, if you wanted to discuss any of the other roles. I'll just put that slide back up. So those are basically the roles that we have at the moment within primary care. I'm no doubt I don't think we have any pharmacists in here. However, I think it was Nasifa is certainly doing a link worker role, and of the others, physician's associate and paramedic. Well, not paramedic necessarily, but the physician's associate. Is anybody interested in that one? In that role?
Yes, I would be.
Yeah, great. I
also can be a health coach for obese people to lose weight.
Excellent. So afterwards, if you want, we can discuss people that would be good to help you achieve that. There's obviously, you know, we have to be trained, and there's quite a lot of specification about who can do what. But so long as you have the qualifications or you're working to achieve those qualifications, then yeah, it's just getting in, isn't it? That's the thing we need to do. We need to get you in. So I'll talk to you afterwards. And
yeah, okay.
Lovely.
Yeah.
Sorry, can I ask, for all the ARRS roles, do you need a science for all of those, even like prescription clerks? Is that all?
No. No. Thank you for asking. I should have pointed that out, Patty. Was it Patty?
Yes.
Okay, so if you run through them, you have to be a pharmacist to participate in the in-practice pharmacist scheme, and certainly for the one that's in the community. The prescription clerk is absolutely a non-clinical role. Now, when I talked earlier about the coming together, the merging, one of my practices merged with another practice during the pandemic. Oh, what a crazy time. And that practice now is knocking 30,000 patients. 30k. They're practically PCN on their own. They have two prescription clerks. That is their role. They are not clinicians. They don't have first degrees in sciences. Okay? But their role is to manage, under the responsibilities of the protocol, their role, they do not step outside of it, they manage all of the incoming prescription requests. And that is a training. It is certainly, maybe Camden did commission the training. I certainly know Barnet commissioned training because I have got 2 prescription clerks working in one of my practices. So yeah, so the GP assistants, exactly the same thing. Non-clinicians, you may or may not have a first degree in science, but you don't need it. Okay, care navigators, we're going to come into that in a little while. The care navigation, I showed you the framework there for care navigation. Care navigation is, you can do the training. It is available. It starts off with something called MEC, make every contact count. Do you remember the triangle? The patient phones up and the first person the patient speaks to is meant to manage the signposting or triage or whatever the patient need is, the person who speaks to them first. And that's called making every contact count. We all know, we have all been frustrated about talking to people in the health service and outside of the health service, and you say your spiel and you have to say it again and again and again. You get passed on to somebody else and you have to say your story again. And that's what the care navigators signposting, that's what that is trying to get rid of. That is, again, commissioned by the training hubs. Care navigation has 4 levels. Those of us in primary care who aren't actual link workers or social prescribers, we do level 1 and 2, the 2 basic levels. The reason for that is because we do not have, you could go on absolutely and get to level 4. The reason why those of us in primary care at front desk can't do it is because we don't have the luxury of 45 minutes to talk to each patient. And that's what level 3 and 4 do. Care navigators, link workers, that's what they do. But there is nothing to stop anybody progressing through these levels. Care coordinators generally sit within each practice. Again, I've got 2 care coordinators. They don't just work for my practice. They are paid through my practice, but they work for other GP practices, and they can do it remotely. They can do it remotely because what it's about is exactly that, care coordinating. They are tasked with searching for patients with particular types of disease, with particular outstanding issues, like they need diagnostics, they need blood tests, they need their height and weight checked, they need for a medication review, they need the flu vaccine, they need the COVID booster, childhood immunisations, and these people are tasked with trying to coordinate everything that patient needs prior to them coming to the practice to see a clinician. You know, there's nothing more frustrating than making an appointment and turning up and your results aren't there, the scan isn't there, the bloods aren't there. And this is what their role is, making every contact count so we don't, waste time when we could, valuable clinical time. So, and then obviously you have to be a trained counsellor. You have to have a counselling degree. Paramedic, again, that's another separate training. We're bringing in paramedics and physicians associates more and more and more. Anybody want to throw in why we would employ a paramedic or a physician's associate instead of a GP? Money. They don't cost as much, do they? I know lots of things are happening, and I'm saying I honestly believe brilliant. We are changing things, and I think the vision we have is great, but there's issues along the way. It's not smooth. It's not smooth sailing. So obviously the health coaches, they have to be trained, qualified health coaches, dietitians exactly the same, podiatrists exactly the same. So if anybody's interested in the clinical or the professional roles, then let me know, and I'll later on I'll get some contacts for you. But I can deal. I mean, my passion is developing the non-clinician.
What is a social prescriber?
Social prescriber. So they came about pre-COVID. They were part of the GP Forward View, and basically they are in our area. You know, we're five CCGs. They came from Help the Aged. They were social prescribers. They sat within Help the Aged team, which is social care. But remember, the 2012 Act means we have to all work together. And they were people who were going to be dealing with our aging comorbidity people. They are frequent users as well, we know, because they have comorbidities. They have lots of things going on, and it's their remit was to enable the patients to access services to assist their daily life, which they could do and which the GP didn't need to do. That's where social prescribing came, link working, and that we have a social prescriber, and they aren't necessarily. I think the overarching organisation that they work under might be still Help the Aged, but there's no age limit to the people she works with. That she will do link working, signposting patients to help within the social care setting. There's no age limit to that at all. But they came from Help the Aged pre-COVID, and again, you know, pre-COVID, I wasn't really a big fan. As far as I'm interested in, is when people are coming to assist us, they need to be helping us first. The practice, they need to reduce the stress that we're under. They need to help with patient health outcomes without necessarily doing a job and then bringing the patient back to us. And that's what we ran this pilot in Camden. It was brilliant. The patients loved it, but it didn't necessarily mean that the patients weren't coming back to us at the same rate they were before. And remember that this pilot was run. It had a bulk of money attached to it. And that money, instead of coming to the GP practice, went to this pilot. And at the end of it, when you have to assess it, it's brass tacks. I told you we're independent practitioners. You know, we couldn't see the benefit because the patients were having a great time because they really loved the link workers, and social prescribers were brilliant. They had the luxury of 45-minute consultations. They had the patients loved it because they were forwarded to people that could help them in other ways, but they still came back to us. So in a way we were losing income but still doing the same work. It's the brass tacks of healthcare. We have an internal market. We have a commissioner provider split. We have independent practitioner status. It isn't easy. So yeah, I mean, now we wouldn't have got through COVID. I know that. There's not only would the practices have had a worse time and much more pressure upon us, the patients would have been sorely neglected, in my opinion. They were amazing. So hats off to anyone who does care navigation, social prescribing, any link working. Very complex. Righto. Any more questions?
Yeah, yes.
Sure.
I would definitely be interested. And if I can, at the end session, have a conversation with you to see what is the acute need of the NHS and what I can provide, since I have an experience in medical care, in the medical field.
Okay, yeah, absolutely. Absolutely.
Thank you.
Of course. And anybody else as well, you can contact me.
Thank you.
Okay, right, lovely. So we'll move on then. So, you know, as I was saying, the concentration, I suppose, is on the non-professional development roles, the way the primary care is looking at using this resource. You know, and just to say that the job is quite challenging and it's quite complex. It is, we are sort of standalone in a way, even though we're working together across practice boundaries. Each individual practice is an individual practice, and the people in it, we're managing this huge amount of data, which is super, you know, lots of people want it. It's really very interesting data. There's lots of customer face-to-face service that we deliver. We've got sick people, we've got worried, we've got dying, you know, we're managing all of this. And it is, you know, just to say that I do say to the delegates, that those of us who are frontline and administrators, I said, do you think you're a caregiver? Do you think you're providing care to the patients? Yeah, absolutely we are, 100%. Every time anybody within a practice talks to a patient, they are delivering care. Yeah, it's simple. It's what we do. That's why we're here. Yeah? So we shouldn't forget that. We are caregivers. Cool. So let's talk about the nitty gritty, shall we? Let's just give you this element. Oh, sorry, I didn't realise you couldn't see my lovely face. This element is about the nitty gritty of what the complexity of what we do. Well, I'll just go through them. You know, we have to, patients' needs, this is what it's about. Registration processes, not as straightforward as you think. Prescription management, massive part. And absolutely safety first. The incoming and outgoing data. So I talk about the new technologies till I'm blue in the face, but every action has a reaction, and it can be, you know, good consequence or a not so good consequence. So for the incoming data, for the patients, it's been pretty good because we've allowed email access, which is 24/7, isn't it? There's no turn off unless you physically turn it off, and I know some practices have done that. But the data coming in is overloading us, but we've no extra staff. And now we have, I'll explain in a little shortly just how many programs that we have to use, that we have to manage, that we have to risk assess and protect because of the law. Of course, it's about data. We don't want it to get into the wrong hands. But it's getting more and more complex. We're settling down. We will find our way, but at the moment, it's quite challenging. We have to talk about your duties as a chaperone. Yeah, where non-clinical staff attend intimate examinations of patients. Obviously, confidentiality, it's our byword. We have to understand about diversity and cultural awareness so that we stay within the core principles. And we have to, you know, talk about vulnerable patients and safeguarding, because mandatory training, mandatory. We have to be trained in safeguarding children and adults to what's called level 2. Every single person in the practice. We have to do that. We have to do equality and diversity training. Everybody in the practice has to do that. We have to do training on helping patients with learning disabilities. So all of this stuff we have to do. It's quite a complex role. And it's really interesting. I mean, it's really interesting. If you're enthusiastic, it's really interesting. So let's test a little bit of your knowledge. Registering patients. Okay, safety, safety, safety. That's our byword. That sits in the front of our head. Everything we do, that's what we start off with. Okay, tell me who is eligible in your maybe you know, just anecdotally, throw it out there. Who is eligible to register at a GP practice?
Everyone?
Pretty much.
Anyone who has his papers and eligible to be resident in the UK.
No, it's not based on that. It's based on the need. Okay, the NHS principles, remember, free at the point of access, cradle to grave, based on need. Sorry, I didn't catch you said everyone. I know we get this, you know, and it has changed. Implementing registration processes have changed full circle. In the old days, we didn't walk around with ID.
Sorry, did you mean who is eligible to be registered or who is eligible to register?
Who is eligible to register with a GP practice?
Oh, right, okay.
Yeah.
Not who is eligible to do the registration in the practice.
Well, yes. Well, it's always going to be frontline staff. That's basically it, because there's a lot of this that goes on, and there's a lot of information that needs to be gathered. I beg your pardon, no. Who is eligible to receive primary care services from the GP? Basically everyone. If in doubt, just register them. What is it that you need to know from the patient? There are exceptions, obviously. There are exceptions, and we'll go through those in a moment. Who do you think? What do you want to know from the patient? A prospective patient attends. Says I'd like to register.
Date of birth.
Even before that.
Name, address.
We're a local practice. We are local. You know, hospitals, they take patients from all over the shop. We're local. And we provide a service 24/7. I know it doesn't feel like that, but you know, patients are registered. They don't stop being registered with us at 6:30 or 10 or 9 o'clock whenever we close. We need to know that they're local. So the address, we have catchment areas. Yeah, and they are quite loose and flexible, especially now because of this remote access. Okay. So whoever is, sorry, I'm just gonna, there's a bit of feedback from somebody. Sharon, I think. You wouldn't mute yourself, Sharon, would you? Unless you would like to say something.
No, I said date of birth, but then we went on to say address, postcode.
Yeah. Okay, so what's happened is, because of COVID, oh, that's great, yeah, thank you. But please unmute if you want to jump in. So we are local, and in the pre-COVID, we were very, very fixated on our catchment areas. We didn't want to be called out for a home visit based on need, clinical need, to a patient who is over in Essex. No, how can we do that? But it's part of our contract. We have to do it. That's why your address was really important. And of course, you know, there's 2 or 3 practices within a mile radius here. Of course, their catchment areas are going to overlap, but it'll depend on, you know, where the practice it sits, and you know how far it wants to go. So it is practice. It's all down to the practice, really. The stipulations, of course, there's stipulations for everything. We do not want a postcode lottery. Okay, the stipulations that say every now and again, I think the last time they did it was 10 years ago, the NHS England or the CCG gets tasked with saying, can I have a look at your catchment area, please? Because if your catchment area goes like this, and then it comes to what one would consider a deprived estate, and it goes out around the deprived estate and then comes back into the non-deprived areas, so you've chopped out You've purposefully chopped out the people who live there. You can't do that. You absolutely can't do that. So every now and again, the commissioners will say, can we have a look at your catchment area? But you know, your address, please be local. You know, and if you wish to register with us and you live in Essex, then the stipulation is, and you must hear this, is that we won't go and do a visit. But you have to know that before you register. Lots of patients would like to be registered where they work, not where they live. Well, now where you work is here, isn't it? I'm working here in the dining area, and people are very annoyed with me. But there we go. That's what I've got. So address. Catchment areas now are very fluid. But you know, we all have them. We are not allowed to exclude areas of high deprivation. Right? Postcode lottery. Okay, so you've ascertained that the patient is in your area. The first thing is practically everyone can register. People who can't are generally people who don't live in your area or people that you've taken off your list already, because that does happen. It's happened in the last 2 years. Actually in the space of 3 months. We took 2 patients off, but in the last 3 years, various practices, we've taken off quite a lot for aggression, really, physical aggression and verbal aggression. So, if in doubt, register them. So, which documents do you need? What do you need to register? What are the requirements, or, you know, what's the process?
Proof of identity.
You say proof of ID, yeah. Anything else?
Medical history. What are the current treatment we're taking?
Extremely important. Extremely important. So the very first thing is, if the patient doesn't have any documents, they are entitled to register. No documents. So, to cast your minds back a bit, we were told, and this is how, you know, and you have to go back to the source documents from the contracts. We were told that as gatekeepers to NHS care, right, we had to ensure that only those eligible to receive NHS free treatment gets it. Well, if everybody's eligible, then everybody gets it. But they didn't quite say that. So there was a bit of a debate, and there's a debate recently in one of our London boroughs, not ours, other side of the city where I'm doing some work, about what documents do you need, must you have? No documents at all. You don't need a document. You know, years ago, people didn't have, you know, they might have a birth certificate, and they probably didn't have a passport either. Driving licenses were bits of paper. I still have my bit of paper, no photo ID on it. So it's about equality and access. If a patient says they don't have any ID, you register them. Now, the thing about that is you have to see the patient. Okay, so you can't do it over the phone, and you shouldn't be able to do it remotely, although there is a project, a pilot going on regarding online registration. Right? So this is us falling out post-COVID into a new world. Okay, and the technology is there, and we're trying to keep up with it. However, there's glitches. There's always glitches, and it's frontline staff who know about these things. So you have to see the patient, because otherwise there's nothing. There is no patient. There is no ID. It's very difficult. And imagine saying to a person who has 3 kids, I have to see all of you. Physically see all of you. Why do you physically have to see the children?
Well, you need to make sure that they exist.
100%. Safeguarding. Children, unfortunately, are trafficked. You have to have a patient. You know, we know this because it's recorded, it's been experienced. Certainly in our sister surgeries within that are very close to King's Cross and all the big train stations, children are registered without parents and they get immunisations, they get bits and bobs and they're off. Don't see them again. Safeguarding, that's mandatory training, safeguarding to level 2. Okay? Frontline staff are doing this. So you know, each practice needs to have a very clear written protocol about registration. Now we have another dilemma coming in. This is all, you know, all this stuff is going on. It is complex, which is why frontline staff need so much support. And generally, we're a lot of the time, because everyone's busy, we're sort of left on our own a bit to muddle through. So we don't need any documents. It'd be good to have documents. Oh, yep.
Oh, so do you need to make appointments to register families and people? Because there could be a lot of people in the queue behind or listening, or it could be difficult for a lot of children all to get together in a busy surgery time.
Yeah. So yeah. It's all, you know, we are bound by information governance and confidentiality rules. We are bound by our contracts. You know, there are so many different aspects of procedure and process and policy all coming in at us at the same time. You're absolutely right. So generally what happens is that we suggest to patients, come and collect. Well, you're local, right? You're local. You don't need an appointment for this. Come and collect the paperwork for all your family. Go away, fill it in, bring it back. Let me see what they look like. Right, you're 7, are you? And you're Mabel. Okay, you're 11 and you're Tom. Right, that's it. That's all we can do, because that's all the time we have. We do. In the old days, some practices I worked for wanted the patients to make what's called new patient check appointments. There's no time for that. Absolutely no time for that. Okay, no time for that anymore. But the reason why we can remain safe, right, is if you have, the only thing we really do want is your NHS number. Your NHS number is given to you at birth these days, and it goes to the cradle with you. It goes cradle to grave with you. When we have your NHS number, when we're inputting the data into our systems, the NHS spine, it's called, goes, I know this patient. I know this patient. All of the other data fits. So I'm going to suck out all the information from the previous GP and suck it into and push it into your system. Safety, right? Because all the information's there. Brilliant. But somebody within the practice, generally admin, has to agree and accept that information. But once that's done, and it is practically instantaneous, if your NHS number matches all your date of birth and names and address. What happens is, that doesn't always happen. Your NHS number and your surname might be right, but the NHS doesn't like that. It has to have a number of factors that absolutely match. And if they don't match and the patient forgot, as lots of people do, it's where you were last registered, the address where you lived, where you were last registered with a GP, not the last address where you lived at. See, someone has to unravel this at the desk. It's got to be, it's quite complex. So that's one of the things that we love is your NHS number, especially as you're not obliged to give us any other data, any other documents. What happens if you've never been registered with the NHS before and you've no NHS number? Well, it's great actually, because you can just enter the information in. You're a new patient, and lo and behold, the system goes, all right, okay, here's their NHS number. Bang, there's a new NHS number. It's quite easy, that one. The problem with that is, what's the problem with that regarding safety?
You have no idea who they are.
We have no idea what's wrong with them.
Yeah.
Because there's no There's no GP to GP. There's no previous medical data. I think it was Raoula said, you know, you need a questionnaire. That's, yeah, the questionnaire. What medicines? What have you had an operation? Have you got an illness? Do you have any allergies? Big one, big one. Are you on any medication? Yeah. And if you're a child, have you been vaccinated? And if you have, which vaccinations? Do you know the complexity of children's vaccinations these days? Ah, mind-blowing. And especially if it comes to you in a foreign language, because then you have to decipher it. Complex things these are. It's not, patients get very frustrated. You're not quick enough. Really? Yeah, I'm not quick enough because we have to get things right. It takes time. And the NHS spine, it's called GP to GP, rejects quite a few registrations because it doesn't like the look of it. And you have to then go and speak to the patient and say, did you really live at number 7, you know, Broadhouse Gardens? Oh, yeah, did you? Were you registered with the doctor there? No, I wasn't. OK, well, can I have the address where you were last registered with a doctor? Okay. See, this semantics, but it really matters. So if they do not have an NHS number, then we have no medical records on them. So the questionnaire is vital. Back to paper. Who do you think inputs the data from the questionnaire?
You, the receptionist, the front line. Frontline, and I'm just going to say this again. Frontline staff who haven't been given medical terminology training. So you're all familiar, I'm sure, because if those of you who use Pinnacle or any other systems, coding is super important. Correct coding even more important. Yeah, coding. What coding does when you get information, we're going to talk about data capture in next actually, but it's really important to get the correct data in with the correct date. Yeah, so if I had my appendix out 20 years ago, then, you know, it should say 20 years ago and not 2 years ago. But patients can't remember. I can't remember. I haven't had my appendix out, actually, as far as I know. But, you know, it is a complex journey to register somebody. It isn't quick, easy, no hassle. And patients don't appreciate that because we have a backlog of registrations, we've got a pile. There's always a pile of patients because patients come in families, 5, 6, you know, a piece, 5, 6 individual documents. And if they're from abroad and they don't have an NHS number, you have to input all the clinical data, right? And you have to make sure your questionnaire asks questions like, you know, quite personal questions, you know. Do you have a learning disability? Do you have any, you know, mental health issues? Patients are reluctant to do that. They don't want to do it because you're not the clinician. You'll be reading it and you're not the clinician. Very complex job. It's not, you know, easy, sign here, in you come. Oh, I've seen your passport. There you go, in you come. Lovely. Okay. Gosh, I've stunned everybody into silence there. So we've gone through registrations. Let's talk about prescriptions. And those of you who fancy being a prescription clerk, I mean, it's a great job. It can be quite challenging because the systems the GP use, the IT systems, don't look the same at the other end at the pharmacists. So we're saying, can you see this? And they're going, no, you haven't done it. Oh no. And then the patient's in the middle and the patient's phoning the pharmacy and the GP practice saying, you haven't done it, you haven't done it, you haven't done it. And there's a glitch in the system. There are always problems with the communication between the GP practice and the pharmacist systems. But that aside, put that aside, what we have here. Some practices, not all of them, my PCN, we share 2 prescription clerks around the practices and they can work remotely, which is brilliant, right? Some practices now have prescription clerks who work with the in-practice pharmacist, right? So they're in conjunction. They very, very close working relationship. Okay. However, all staff, any member of the team that manages, picks up, touches, looks at a prescription request has to be trained. You've got to have a practice policy and procedure to follow. You absolutely do. And there has been, during COVID, of course, we know why. Secondary care has been closed. We've been trying to manage all of these patients. We have higher levels of anxiety and depression that we had pre-COVID. We've got a lot more of patients that haven't been diagnosed that have been coming to us. They couldn't get diagnosis, so they couldn't get diagnostics, so they couldn't get their tests done. So we've increased painkillers and all this type of stuff. So there's a massive rise in prescriptions, and there has to be two, but it's got to be accepted method of submitting requests. Why would I put that in its own box?
Well, for time management, if everybody did it in different ways, it'd be impossible to manage.
100%. It's also arbitrary, right? So I like Bob. I like this patient, Bob. He can call me up and I'll accept it over the phone. But this other patient who's got a list of medicines, no. You have to either put it in paper or email it or request it GP online. Arbitrary. We cannot make the rules up as we go along. This is the point about postcode lottery. It's about upping our standards. It's about having a good high level of patient care with safety at the front. You take something over the phone, you get it wrong. Right, we're not clinicians. The patients are given access to their online services if they want it. I have an online account where I log on and I request my medicines, all there for me. I don't have to contact the practice, it's all there. Okay, you don't choose to do that, then it has to be in an accepted format. The accepted format, because safety first, is in writing, in email. And it can't be down to the person who's taking the call. The exceptions are always there. Those exceptions are people like my mum. She's 91, right? She's also a bit deaf. She has no access to a virtual world at all. She's not interested. She's lost. I've given her 2 mobile phones because she lost one. What do I want that for? Right? So we always have exceptions because it's safety first. Vulnerable patients, patients with learning disabilities, people who haven't access to online services. But it's got to be an exception. And if you're not in the exception group, then you have to use the accepted method, which should be in writing or via email or online. Over the phone, it's not safe. But your protocols and your procedures should be written down for you and you should be trained in it. Safety first. So, next line. I'm going to go back up to the top line in a minute because I've got a horror story. But anyway, repeated medication, acute medication. You know the difference. Right? Repeat medication is exactly that. You're on it. And when it runs out, you carry on taking it. What's an acute medication?
Immediate need.
Absolutely. Generally, one-off. Antibiotics. Yeah? Hay fever tablets. They're seasonal. Sometimes you get acutes because if you're hypertensive, so if you've got high blood pressure, then of course you want to manage the high blood pressure and it'll be on repeat medication because you don't want your blood pressure to go up. However, at the start, what we're trying to do is bring it down into a normal target range. And we don't know, do we, till we try how much of the medication you need to bring it down into the normal range. It's called titrating. So until you've actually got the right level of medication going into your system that allows your blood pressure to stay safe, we're going to give you more, bring it down, or put it back up again. So you can't put that on repeat because it's movable, it's changing. So even so, the patients, again, the frustration, and it's about the consultation itself. Patients are worried and they're not necessarily always listening, and the doctor will say, I'm going to put you on this, but I want your blood pressure checked in a month's time. It might go up and down, but they're not necessarily hearing that, which is why you can't, oh yeah, I see your medication, I'll just do it for you. You can't do that. If it's not on repeat, then it's not repeatable for various reasons. But the patient gets through to us and gets a bit narky. That's how these things go up. Thousands upon thousands of calls like that. So repeat is exactly that. Acute, one-off, should be. What happens when you get a request and there's a whole list of repeated medication which is there and an acute medication? What would you do? So I'll tell you the story, which is what, you know, I want you to remember some of the slides I've already shown you. I want you to remember the sepsis slide, right? Okay. So we have, this is us at front desk. This happened. Very close, surgery. So underneath repeat medication and acute medication, I've written time scale to action, right? So we cannot do things like that. 27,000 patients, you cannot turn around a prescription in a nano moment. You have a virtual stack or a real stack of things, of paperwork to get through, of requests. We say, most of us say, it'll take 3 working days. If it's routine, if it's repeat. Okay? If it's absolutely fine, it's all there on in your file. It'll take 3 working days, not Saturday and Sunday, right? So you put it on Friday, it'll be ready on Wednesday. 3 working days, right? That's what we say. Acute, so the patient is asking for something that they've had before, but it's not on repeat. So that's an alarm bell. Wow, 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 wow. Safety first. And when you do your prescription clerk training, or if you're not a prescription clerk per se, but you have managed prescriptions, you will know this in your prescription, in your training. That's an alarm bell. That is triage, safety first. Okay, so the story is, so a gentleman, he's 91 actually, and unlike my mum, he uses email perfectly acceptable way in this practice, the practice that has this issue, perfectly acceptable way to request his medication. And because he's elderly, he has quite a lot of comorbidities, so there's a huge amount of repeated medication. He also, unfortunately for him, he's 91, he's a little bit sort of housebound really, and he's got leg ulcers in his lower limb, generally around your shins and ankles and that area. It's where all the blood sort of pools if you're not walking around a lot. You've got bad circulation down there, and it's very common, unfortunately. And these ulcers do take a while to heal. They're quite poor. Granulation is quite poor. Anyway, so he's got acute prescriptions for dressings. And so the request comes in, it's got all his medication, and plus he says in his request, can I have some more dressings, please, because my wound is oozing more than it did, and it's leaking, and I need to change it. Came in on a Friday. The person looking at it wasn't a prescription clerk necessarily, but was admin. Put it on the stack, read it. Okay, yeah, looks all right to me. 3 working days. Came in on a Friday. It was actioned on Wednesday. What happened during that time?
He got sepsis.
Got sepsis, yeah. And he's extremely unwell. Patient's family, understandably. So I'm saying, you've got to have a protocol. That protocol has to ensure that there is safety at its heart and the triage. So there we go. So the policy now, well, it sort of was anyway. It's just that the person reading the letter, the request, had no concept of triage. Red flag triage. Right. So that's time scale to action. And lots of things are urgent because the patient A has left it too late and is on their last repeat medication. That's urgent. You know, you can't let a diabetic or an asthmatic free from their drugs when they need them. They have to have them. So that's urgent. We have to deal with that. And that's when you have to say, when do you run out? Sorry, when do you run out? How long have you got? That can't wait 3 days if you've got no, you know, diabetic medicine. And of course, then there's the review date. So even if you're on this repeat medication, it's working well and everything's dandy, there's a review date.
Wouldn't it be better if they just had repeat prescriptions sent automatically? If they automated that and then just had reviews in?
So they tried that. That was called repeat dispensing.
Yeah.
So there was a method many years ago which we were incentivized, enhanced service outside of the contract. We were incentivized to set up repeat dispensing for everybody who was on repeat medication. So you would give 6 months and then there'd be a review, and the patient understood you don't get any more till you come in for review. Yeah. Right? Maybe 8 months or something. 6 months, I think, was the maximum. But the systems didn't work. That's basically it. The connectivity just didn't work. And again, as I said before at the start, what we were seeing in this end was completely different to what the pharmacists were seeing. So
it just seems mad that you've got somebody sitting there with repeat prescriptions having to go through 3 working days, when actually, if it's a repeat, that should be automated, really, shouldn't it? And then, as I said, obviously build in the review so you don't stay on your repeat medication for longer than you need to. But if it's lifetime stuff, you know, I have an epileptic husband who's on medication and he's constantly running out unless I work it out that he's running out because he's useless.
I mean, the pharmacist can help with that. They can do the ordering on time.
Yeah, I constantly go to the pharmacist. In fact, I'll have to go at some point today. She said, "Oh, I've got to go and collect it." But it's, you know, it's almost like that sort of stuff. You think if you can take stuff out, it's a bit like putting this in place to free up GPs. It's almost like things you can.
Absolutely, and I would encourage the use of local pharmacists again and again and again.
Yeah.
So so we've talked about pharmacists. There's 2 new roles. There's 3 new roles regarding medicines. After wages, medicines are the highest cost to the NHS. So I know this because I've been around a long time. You'll have somebody who's on 8 medications. They will just routinely request them all the time, even though they're not taking them. They will request them even though they don't want them. There's a syndrome called the good patient syndrome. Okay? I've been into houses, I've been to homes, and I'll go in and I'll look around and there's just bottles and bottles and packets, unopened, unused. Hence this tremendous surge to get pharmacists reviewing medication, really reviewing medication, not in a 15 minute thing, but really going round and looking at patients' usage. Patients who are on 5 or more drugs are not targeted, it's the wrong word, but are highlighted through our systems all the time. Do these patients need to be on all these drugs? Or is it 6 or more? Can't remember. There's also a thing, isn't there, about what should be prescribed and what patients should buy. Again, very controversial. Very controversial. This referral scheme I've talked about to try and release time to care for the GPs, where we actively signpost the patients to the pharmacy. The patient backlash, there's a backlash against that in certain areas, and the backlash is because the pharmacist will very clearly and clinically sound say, "Oh yeah, I've got some cream for that," or "You can take this tablet." But the point about it is it's over-the-counter medication. The patient has to buy it, and the patient goes, "Thanks very much," and goes back to the GP and says, "The pharmacist says I need X, Y, and Z, or I need a prescription." That didn't alleviate any pressure from the GP practice, did it? And it also means that the patient isn't going to go there again. Complex world, isn't it? It's a complex world. And the GP is in the middle of this complex world because we're the gatekeeper, we're the waistband. Everything comes to us. Okay, review date. So sometimes we don't do prescriptions for the exact amount of time. So instead of giving a hypertension drug because the patient's got hypertension for the 2 months, we say we're going to give you 1 month because you haven't been for your blood tests. Right, so can you go for your blood test, please, and have a review? This is in your protocol. This is all in your protocol. Should be. Okay. Oh, this is the thing now which is having us on our knees. On our knees. This is called the Lloyd George file. And this is the first computer. I mean, I can remember pre-computer. I know. I keep saying it. I am old. And we really have to take stock because this is really important. This is really stressful for the practices and the admin teams. Super stressful. Huge increase in GP consultations. I've shown you 2 million more a month. If you're going to be consulting 2 million more appointments a month, at least 50% will mean a referral or for a diagnostic or a review to come back. So if you're sending patients out to other places, you're going to get data back in. Okay? And we're seeing 2 million more patients a month. Okay, we've still got people working remotely is great. I absolutely think that they can really help. However, they're not part of the team. We need to recreate our team cultures again. It's so much easier to get off your chair and say, listen, I know you spoke to Mr. Jones last week. Can I just check if this is okay? It's difficult to do that remotely. Yeah. Some practices still have staff shielding. And they are accommodating that because we're a health service and we need to look after our staff. But I don't know how long that's going to go on for. Remember, everything has to be screened. Every single piece of data that comes in, just like that prescription request, as innocuous and plain as it is, it's got to be triaged. Every piece of data. We have some of us have 24/7 access virtually. That people can send us things. Okay. The clinicians now, according to eConsult, I'm not sure if you use or are familiar with eConsult, they keep doing lots and lots and lots of research because the systems are learning. Every time people like me press a keyboard, the systems in the background are all learning. Okay, and what they're saying now, they're saying that GPs really want to know exactly why the patient's coming into them. Everything's got to be triaged. And we're doing that virtually. The virtual triage system is eConsult. It's Patches, it's MJOG, there's other ones out there. Yeah. And of course, we now have all of these other roles. So our patients are being seen by these other clinicians and professionals. They're going to send us information as well. So it's coming at us hook, line and sinker, whatever the expression is. So, we've also got the COVID vaccination that coding or trying to get coding for people who've had their vaccines abroad was a tortuous event. Okay, we're sort of over that hump now, but for those of you who did anything with Pinnacle, it was quite tortuous. So we have a lot of things coming in. And this is a really busy and mucky graph, but it just tells you what's happening. In the middle there, all arrows point to admin. Okay, they don't go straight into the clinical team. All comes in and it all has to be triaged by admin. And remember, we must always make sure we have an access avenue for the patients that are vulnerable or can't use technology or just a preference. We can't force everybody to one route if they don't want to. Technology does that though. You know, press 1 if you want this, press 2 if you want that. But we cannot allow ourselves that because we have vulnerable patients. We can't do it. So this is the ultimate in workflow optimization. Remember the high impact action points. Number 5, new workflow systems. So if you have a look, I hope this is the NHS graph. If you have a look, it's down at the very bottom in purple. 40 to 50% of the incoming data will be dealt with immediately by a non-clinician. Take all the actions that need to be taken and will only pass it through to a clinician under various stipulations. Okay, so when I first started, 100% went to the GPs. 100%. And the GP looked at it and go, oh, ask the nurse, she can do those vaccines. Yeah, that's about the only time I remember them ever shifting anything off their plate. But now, ultimately, according to the Brighton and Hove model, only a maximum of 20% of the documents that come in should be seen by GP. Maximum 20%. Safety first. Safety first. All staff managing and handling incoming and outgoing data must be trained to do so. Must be trained to encoding in medical terminology and at the practice protocol. Right? That's it. I can tell you just how many times I've seen heads shaking at me when I've said, oh, have you been trained? No. There we go. We know if we're doing this role, and it's a super really responsible role, we have to know how to read a clinical letter. What happens to people who are never trained at picking up on the job? They look at the clinical coding. They look only at the coding. And they focus on that. You have to read the bits in between as well. You have to put the letter into context. Content, yeah, clinical words. Do I code? Do I not code? But it's the context. It's the whole person. It's the whole letter we need. Obviously, the first person, it's a bit like make every contact count. The first person who, the more hands, I suppose, virtually or real, a piece of paper or a document goes through, the more errors will occur. That's just the way it is, because no one will take responsibility. No one takes full responsibility. So the person who sees the letter or the document first has to capture the data. You can only capture the data if you've been trained, obviously. You have to know when something needs triage. Is it urgent? You need to know, even sometimes there's absolutely nothing for the GP to do, but you must send it to the GP for them to see. In what sort of circumstances do you think that would be? There's absolutely no action for the practice to take. There's no action for the GP to take, but the letter must go to the GP.
It could be, sorry.
Yeah. I'm gonna go on again and again about safety. Children generally. So most protocols I've seen say the doctors want to see every letter. Doesn't matter what it's for anybody under 16. Safeguarding. It's just having that eye. When children aren't taken to an appointment, it's called, and there's a code for it, it's called not brought. Now, if you as an adult don't turn up, the code is did not attend. A child cannot not attend. A child has to be taken. That's the theory. So, you know, your protocols, they're as wide, they should be as big as anything, because there is so many computations of what you need to do when you manage data. Triage, code at first point of sight, the first person. That's how you ensure safety. You have to follow your protocol. It's a bit, and of course, you know, you have virtual, you've got all paper and you've got virtual information coming in constantly. And again, exactly the same concerns are brought up every time I talk to staff. So there's a bit of work to be done there. Okay, so what's this? Who's the lady in the black frock? Anyone? Next to all the young dandies and the beautiful young woman.
Is she a chaperone?
She's a chaperone, right? And chaperoning, obviously not like that, because, well, we don't have tea dances in the practice anymore. Yeah, this is a job. It's a really, again, responsible job. You know, what would you say the chaperone does?
Accompanies people to the medical practice or where they need help.
Absolutely. You are there to, the acronym is PAP. I'll go through that in a minute. You provide support and assistance. To whom are you providing that support and assistance?
Patient.
And
the doctor. And the doctor.
Absolutely. You're there for both. Right? That's the thing. Okay. The purpose of the role, I'll go through this in more detail because it's really important, is to witness, is to provide assistance and support, but ultimately it is to be a witness to ongoing consent to the procedure. Very specific. Now, the doctor can call a halt to an examination. Generally it's the patient, but the doctor can as well. You're there for both. You're an independent witness, but you're there to provide assistance to both. What's an informal chaperone? We're formal chaperones. Informal chaperone?
Could be a family member.
Absolutely. You'd always expect a child, well, you'd hope, to turn up with a mom. Somebody, young adults can bring their informal chaperones. People with vulnerabilities, learning disabilities, somebody who needs a carer. We know what informal chaperones are, but they are not formal chaperones. They can never take the place of a formal chaperone, and they shouldn't be allowed to. Very, very important role. Now, definition. A chaperone is present as a safeguard for all parties and is a witness to continuing consent to the procedure. Really, really important. Now, I choose not to be a chaperone. I teach chaperone training. There's 3 hours on this because of the nature of what it's about. I can't, I deal with complaints in the practice. I have to distance myself in some way, right? Because, I'm not saying I'm pushing myself away from the patients. I just need to be a little bit further away because I have to be an objective. If there's a complaint about a GP, then, I need to be completely objective. So I choose not to be a chaperone. So this is the PAP acronym. Provide emotional comfort and reassurance to the patient. Absolutely. Patients, there's always a first time for an intimate examination. It is to assist the clinician in the examination or procedure. I don't mean get in there, I mean moving a lamp, helping the patient onto the bed, making sure, the patient's comfortable. Say, are you comfortable? Maybe holding their hand. It is to assist the patient, obviously. It is to act as an interpreter, because chaperone can be interpreted as well. In some areas, that's exactly what they do. They are translator chaperones. It's really good. It is to ensure all behaviour is appropriate, not just the doctor's, the patient's behaviour. There's quite a few cases where the patient's behaviour has been inappropriate. And the doctors said, I'm not seeing that patient again, and the patient's complained. So it is to protect staff against allegations or attack, of course, and is to protect the patient against abuse. So it's a very, very significant role because, you are going to be the person who they may see at the front desk going, yep, Would you like to take a seat? Would you like an appointment? Blah, blah, blah. And then you're going to step out from behind your desk, go into the consultation room, which is sacrosanct. You never go in there, right? And you're going to stand and stare at their intimate body parts, right? That's what a chaperone does. There's no point going into the room and staring at the wall. That is not what chaperoning. It's PAP, provide assistance and ensure that you are witnessing ongoing consent to the examination. Right, that's a step too far for some people. And if you've been in the job as long as I have, you've got previous, I don't like that phrase, but you know what I mean. I've come across lots and lots of patients in challenging situations, and I don't necessarily want to be involved and going in and chaperoning. Chaperoning is very intimate. It is a big role, and there aren't. Who do you think needs a chaperone? Who would you think would need a chaperone?
A woman being. Sorry.
Yeah. Sorry. Carry on.
A woman who's going to have a smear test with a gentleman doctor.
Absolutely, that would be a very good example. Anybody else?
A vulnerable person.
Absolutely. Just to say, any patient at any time for any reason can ask to have a chaperone. Male, female. GPs, you will see they write in the records, chaperone declined. It doesn't matter your sex or anything. If you want a chaperone, we are meant to ask everybody. If we're going to do an examination, would you like a chaperone? Doesn't matter who you are, and really doesn't matter which part of the body you're going to be checking. If it's children, there's generally an informal chaperone there of a parent or responsible adult. GPs can still, and they should, say, can I have a chaperone? The problem is, of course, that they're children. They don't want more than one person staring at their intimate parts, so there is, again, there's issues and issues and issues with everything. But so long as we try and keep the focus on the patient to allay anxiety and worry for the patient, then, we're halfway there, really. You might choose not to be a chaperone, even if you've had training, like me. It's a step out of your usual role. You will be touching a patient generally and looking directly at intimate body parts. Okay, so that may not be to everybody's liking, but absolutely anyone can have a chaperone. And GPs especially do. A lot of male GPs request chaperones, even if the patient says, no, I'm all right. They've got a sixth sense and go, no, well, sorry, we'll have to have a chaperone for this. Quite entitled to do that, quite entitled. They have to protect themselves. Okay, so again, obviously, especially children, children will be their first time, some young adults, it will be their first time ever having an examination. We have to remember that some children, you've heard of the Gillick-Fraser test. Victoria Gillick, she was a Catholic, quite a devout Catholic. She had quite a large family, and her daughter, who was under 16, went to the GP and got the contraceptive pill, and she basically took it straight up to Parliament. How dare he? This is a child, parental consent, blah, blah, blah. And because of that, the law was changed, and we now have something called the Fraser competencies. And Victoria Gillick lost her case, and the government brought in the Fraser competencies that says when I'm with somebody under 16, I have to assure myself on 5 or 6 counts that this young person in front of me understands what's happening, and if they want the contraceptive pill, I can issue it in confidence, with confidentiality, and we won't disclose it to the parents. There you go. So that all
Sorry.
you know, scared the life out of me there.
Oh,
Yeah.
I'm so sorry.
Yeah.
Sorry, did I understand correctly? If the patient says or declines a chaperone, but the clinician would like a chaperone there, can the GP override the patient's request not to have one?
It's happened. It's happened because, you know, GPs don't like to say no. They don't want to challenge patients or anything. But one GP I know locally, he examined a patient. She behaved inappropriately. He didn't like it. He didn't like it. It unnerved him. He said to her, "Do you want a chaperone?" She said no. Okay, so the next time she comes in, and she would only see him. Again, she needed a physical examination, intimate examination, and he said, "Would you like a chaperone?" She said no. He says, "Well, I'm going to have a chaperone," and she said, "Well, I don't want one." He goes, "Okay, you can. I'm sorry, but I'm not going to give you an examination. You can see another doctor." So she took him to the GMC. He had a complaint made against him. It wasn't upheld. However, who wants that? Yeah, he knew there was something odd. He didn't like it. So yeah. Yeah, it's nothing straightforward. You know,
what happened with this? Sorry, what happened with the GMC when they had that complaint? Did they throw it away?
No, they never throw anything out. They investigate it thoroughly. He was called to give evidence.
I find this so because my son's a doctor, and they started to practice in fear, and this shouldn't be. This is so unfair.
Agree, absolutely. I know, and okay. So I was slightly involved in that because they asked my opinion because do complaints, and I said I really do think you should politely write to this woman and remove her from your list of patients. You cannot be meeting her in the corridor when in the waiting room passing. There needs to be some distance. She's behaved inappropriately. The GMC had not upheld her complaint. You need to take action. Protect yourself. Did he do it? No, he didn't. So what happened? She transferred her attentions to another male GP, and exactly the same thing happened again. And then they took her off. I'm like, well, don't listen to me. What do I know? But doctors don't want to be hurtful or confrontational. That's the opposite of what they do. So yeah, I agree. It's just not fair. It really isn't fair. There's many cases, Yeah. Okay, so we you get the point. Remember, an informal chaperone does not override the need for a formal chaperone, and informal chaperones cannot be formal chaperones. Right, you must remember that. And one of the things that we have to, I try and remind everyone, is you need to write down in the records that you were a chaperone, your name in their records, and you saw nothing inappropriate happen. You have to write that down, because in the event the patient says, actually, he did, I was touched inappropriately, you've no record to say you were even in the room. So it's very responsible. Yeah, here's a case, real case. One afternoon, teenage girl accompanied by her mother consulted a male GP because of pain in her ear. Right? The mother left the room when a mobile phone rang, and the GP continued with the examination, which included an otoscopic examination of the eardrum, right up close, right? Sometimes they might, if it's eye test, it usually happens with eyes, but this was ears. You will dim the room, you will dim the light and stare in so you get a better view of the retina. Okay, there's been a couple of cases where the GP basically says, turn the light off, didn't explain himself very well, lunged into the patient's face with his scope, and the patient went and said the GP was trying to kiss her. Of course it was. Well, it wasn't, but no chaperone. That's for an eye test. That was for an eye examination. Yeah, that went on for a bit. So this one, a week later, the GP was distressed to learn that the girl had alleged he got much too close. She accused the doctor of deliberately brushing against her breasts and of looking down her top. That went to the GMC. So this young fella, it's such a shame. He was new in practice. It took me, he really didn't bounce back from this very quickly. And he said, look, time's of the essence. Your mum left the room. So he was chastised for actually continuing with the procedure. He was chastised, but he was chastised because he should have had a formal chaperone. And he said it was his tie. Back in the days, they wore ties. So there we go. There we go. So one of the things is, remember, we're understanding the individual. Rules. There are rules in every culture, religion or ethnic group, but do not judge a book by its cover. Do not assume that because of the look of someone, they're going to behave in a certain way. Very much that way is very risky. We lived next to a hostel, we practiced next to a hostel, and it was a Catholic hostel, and it had lots of people who were travelling alone and coming to work in this area, and so they would be put up if they were, had connections. And we had, a nun, and she was over here to do a nursing course, and she was pregnant, but she went to see one of my lovely GPs who didn't ask her the question because of how she looked. He came out of the room and he went into the senior partner, and he said, I remember it. I felt so sorry for him. He was so shocked. He went into the senior partner and said, look, she's got this symptom, that symptom, the other symptom. I'm stuck. And my boss said, have you asked her if she's pregnant? And he went, no, she's a nun. And my boss said, what are you, an idiot? You're a clinician. Everything's pointing that way. Go back in the room and ask her, has she had unprotected sex? And of course she had. Yes, she had. So don't judge the book by the cover. It floored him. And, my boss was like, yeah. So med school, she said, God, don't get, you cannot let your own prejudices, life, culture get in the way of safety of the patients. So just to let you know, we're a diverse population. I didn't have to tell you that. This is basically the breakdown. And of course, all of that will be different for wherever it is that your practices are going to be, right? We have practices where only 30% of the patients English is their first language, and then we have the complete opposites. Right? So you're going to be working in a very diverse communities, and we have to do, as I said before, we have to do equality and mandatory equality and diversity training. And our job is to treat everybody with respect, provide services on the basis of need. Okay? And one of the things about the postcode lottery, as sure as eggs is eggs, is those who are able to speak up and speak loud, not necessarily those in most need, or access more services than others. So we must remember that, we're here to manage, to respond to needs. Great. And I think it's another tea break, guys. Lovely. Welcome back, everybody. Information governance, confidentiality. Like I said before, so many people want a piece of our information. Big pharma, especially. It would be Christmas and birthdays forever if they got hold of it. And obviously, there's been quite a bit of controversy, hasn't there, about the NHS, letting our information, pseudo-anonymised as they call it, out of the sphere of, the records. Well, we can talk about opting in, opting out later, but basically, we're the keeper of data, and we need to protect it. But that aside, we need to talk about confidentiality. So when I first started, we used to, here's a piece of paper, please read it and sign it at the bottom. And that's you saying that you'll keep everything confidential. in the doctor's surgery. Anything that you hear, anything that you see, anything that you read, it's all confidential. Now, which is always struck us as quite funny, because if you went to the desk at front reception anywhere and start talking to the receptionist, everyone else could overhear you. Yeah. Name, date of birth, yeah. What was that again? What cream for your hemorrhoids was it? What? Yeah. CQC, when they used to first visit, when they many moons ago, they always ask the question about, what would you do if somebody wants to speak to you at the desk and the area is full of patients? So we'd have to work around that one, because we didn't have any cubby hole. We still don't. I don't know any surgeries that do. You have to. It's difficult to maintain confidentiality. It's difficult not to be overheard sometimes in doctors' surgeries. But like anything, we have to have annual training. We have to have annual training in confidentiality and information governance training. The reason why it's yearly is because things change all the time. Look what's changed. The law and the training is still trying to catch up with what's happened. Okay, prior to COVID, we weren't giving out the nhs.net email addresses for patients. We weren't accepting emails from them. The email system was used solely for the NHS family. Okay? Clinician to clinician, clinician to practice, community services would email us. We would email some referrals out that way. Wasn't for patient use. But when the doors closed, when the world collapsed, we were still here, still at work, so we needed to have another avenue of contact that we could give the patients. We have a duty of care. So we opened up and brought in all of these new programs, systems to enable us to talk to the patients virtually. Right. Again, got to have a practice protocol. You've got to have a policy. We've all got to have what's called business continuity plans, in case that, like the 2017 hack I told you about, in case that happens again. One of our local practices did think they'd been hacked because everything went down. Phones, everything. Nowadays, our phone systems are connected to our programs, our medical programs, so even more connectivity, and as was theirs, everything went down. And so they've obviously, in their business continuity plan, they've got mobile phones that they can use, which isn't any good if you have no system. But they thought they were being hacked until they obviously went round to a neighbour or something, and I think BT, British Telecom, had cut through a cable. I'm laughing. I mean, well, it was only funny from afar. The poor managers there, they were tearing their hair out. Friday afternoon as well. So there we go. A rare occurrence, but that's why you have to have a business continuity plan, and everybody has to know what to do in a breakdown of service. If there's an inability to provide the service, you have to go to your business continuity plan, and you have to know exactly what your role is in there. Because sometimes you get allocated a role that you will tell everybody who's not at work what's happening, just in case it's on a Monday, they turn up on Tuesday and they don't know about it. Things like that. Everyone's got a bit of a role when the service fails. Okay, right. Confidentiality. Why is confidentiality important? Anybody hazard a guess? Why would confidentiality be really important for yourself in the practice?
Safeguarding.
100%. We do not want to disclose information unless we have to. Safeguarding is one of those things we're allowed to disclose. We're allowed to disclose information when it's been requested regarding safeguarding. One of the basic tenet of confidentiality is That's how we build trust with our patients. It's the fundamental golden thread that runs through the patient relationships. Trust, trust, trust. It's a bit like the health coaching. Somebody trusts you. If you go to someone for advice, someone gives you advice and you don't like them and you don't trust them, you don't rate them, you're not going to listen. If you go to somebody for advice and you do rate them, you do trust them, then you're going to listen and you're going to take their advice, you know, and you're going to reflect on it. And this is, you know, one of those things that GPs talk about, building trust with patients. Confidential. You tell your GP, okay, it might go to another member of the team because there's a referral, there's something else. But that's the golden rule. The GPs don't disclose information unless there is a legal requirement. So that is definitely a golden rule. And I can tell you, obviously, I've got a few cases where breaches were made and lots of unfortunate things happened. I will come to those, which are mind-boggling, but there we go. And this is so when we talk about those roles, the ARRS roles, you know, lots of people in the profession that has a front-facing job will be given coaching skills training, yeah, communication skills and coaching skills. And this is one of the things that they hang there. You know, if you're going to do it well, you have to gain the trust of the patient. Okay? And you gain the trust by ensuring that they believe, you know, that they trust you and that you're confidential. Unless they ask you to tell the GP, you go into the pharmacy. Unless the pharmacist occasionally says, can I send this information to your GP? And if the patient says no, it doesn't go. That is out of the window when the patient goes in and says, can I have a flu vaccine, please? And the pharmacist says, are you in an eligible group? And the patient says, I am, which means it's a free delivered service. Then the pharmacist says, the system is set up, I can't give you a vaccination unless I can tell the GP. So this is the weird grey areas we're in that haven't really been cleared up to some patients' satisfaction. Me, I don't care. You know, of course I'd let the GP know that I'd had a flu vaccination, but some patients don't want that. But we are duty bound in some areas to disclose. So this is the textbook definitions. They're from the BMA, the British Medical Association, and these are their stipulations. Basically, I will not divulge, right? A little bit like the priest's confessional. Yeah? We all know, all staff employed by or are contracted, remember, GPs, independent status, all staff employed or contracted to the NHS may be disciplined following a breach of patient confidentiality. So we all know that because we have to do annual training in it. However, even with that annual training, there's occasionally quite big mishaps and big ones. So the reason why we have to do yearly training is because the consequences are massive if you get it wrong. Massive. There's a case, I think it's in, I want to say Scotland, but I don't think it is Scotland. There was a payout and it was 50 grand. 50 grand. And it was the hospitals, one of the trusts had to pay it out. They sent somebody's discharge letter to their GP following a very major procedure to the wrong GP and the wrong patient, because now I'm sure you know you get sent whatever letter is being sent to the GP, you generally get a copy too. So it went to the wrong GP, so there's a whole GP practice there that had access to that information, and it got sent to the wrong patient. Now the Trust got fined 50 grand. And it's only because, not only because, but there's a duty of candour. There's a duty to be honest. Now, the GP practice, the trust wasn't honest. The trust didn't disclose that they'd done that. What happened was that the GP practice disclosed it. So the GP practice took it. It was an incident, a significant incident, because it was absolutely, this patient had absolutely nothing to do with this practice whatsoever. And so they disclosed it, and then, you know, once it's been disclosed, it gets investigated. So the trust was fined, and that was, and the fine, when you read the bump around the ruling, is because that's the one that they found. It's just the one that they found, just the one breach, but there could be others. Yeah. So it is a breach of the law. So criminal prosecution could follow. I mean, it rarely does, but it's the law. You know, we could be prosecuted. The GP contract. So that's the breach of the law, and there's a breach of your contract. Okay? You breach a contract, it's a big thing. You get referred to the GMC if you breach your GP contract. Okay? You don't want that to happen. Obviously, you have to meet CQC requirements. If there's a big data breach, you could be closed. That's, you know, they can close you down. Okay. In any case, regardless of what the law and the CQC, you know, we want to protect our local reputation with our patients. We don't want, you know, patients to be, you know, writing on TripAdvisor that we're terrible, or taking claims out against us on, you know, some patients are very litigious, very litigious. And there are massive consequences. I've talked about the fines, and certainly people's, you know, personal feelings. They will take claims against us. And it's all about trust, isn't it? We want the best outcomes for our patients. Confidentiality, information, good, strong information governance, all good for building trust, all good for building trust. So we need to protect patient data as we do our credit cards and our phone. I had my bag, my own fault. I had a purse stolen and a pair of glasses. These cost £100 to replace, in Aldi in Birmingham. And yeah, I can't tell you that was about 3 weeks ago. I can't tell you the hassle. Thank God they didn't take my phone, is all I can say. There we go. There we go. It's an absolute minefield. So I just want to remind us, I keep doing this, but I need you to walk a mile in our moccasins, as that old expression is. What has happened during COVID and where we are now? As I said before, the GP forward view, time to care, all of this was coming in, but it was coming in at a snail's pace, independent practitioners. I don't like that bit, I'll take that bit. I don't like that bit, I'll take that bit. So the practices, GP primary care was slow to latch on to what the government's vision was for, you know, what they were fine doing their own thing, thank you. They'll look at it later, they're too busy. Well, COVID came. There's no too busy now. We know what busy is. We're in it. But this is what we have. These are some of the systems that I haven't even got them all in. I'm going to go through them. The database that we work with, generally in Camden and Northwest NCL, North Central London, which is where we are, is EMIS. System 1 is the second biggest system. On top of that, we've got something called AccuRx. Does anybody know anything about that? This is a brilliant, I love it. It's a brilliant program that allows us to text and to receive through your phone. So we can receive information, we can send information, and we can receive it. It's brilliant. Absolutely love it. And it goes straight into the medical records That means that people like me don't have to do a whole load of keystrokes to extract the data from this system, make it okay to get into the next system. AtCrux is brilliant. These are all competing against each other, remember? We have eConsult. Are you familiar with eConsult? Virtual platform to contact the practices. Remember, every keystroke we make, every keystroke I make, well, not particularly the patients, but every keystroke we make, the systems are learning about what to do next, right? So they follow the patterns, which will mean, and I say this to all of my staff, our jobs are sort of going to be done for us, right? Because if it knows that I always take this code and I always put it here, because it's followed me doing this thousands of times, it will learn to do it for me. Okay? So I tell all my people, don't be afraid of it, embrace new technologies, do not sit in a Luddite position, right? Look forward and embrace it. We are the human in the machine. The unique selling point is us. This is local care provision to patients. They do not want machines doing everything, and neither do I.
Mary, can I just sorry.
Yeah.
When I see advertisements and it says you have to have prior knowledge of EMIS, and you have to have prior knowledge of this, that, and the other. I mean, I'm very techie. How much prior knowledge how difficult are these systems?
It's not difficult. Absolutely not difficult. The problem with EMIS is, okay, so I do something called coding, and I do document management, that whole thing about taking documents, managing them, actioning, coding, all of that. So I train all of that. When I come to train, staff often tell me, can you show me which keystrokes to use to get this particular... Okay, if you go down on the left-hand side, you will see DocMan. 1, 2, 3 from the bottom. That system is a system that you can... Not every practice uses it, but most practices do. And that system sits next to EMIS. It's a separate system, but it sits next to EMIS and it talks to each other. Right? In the old days, it was convoluted. You had to suck out the document from DocMan and put it into the patient's records. Now that is more streamlined because it's learning all the time. Those two, the EMIS and DocMan, are the only really. There's some learning to be done on that. There's quick fixes. There's much more, detailed keystrokes. I know how to do it, but I am not allowed to show people how to do it. I can't have the system. I've got away with it once or twice, but I don't like to do it because I don't want to be, taken to task by EMIS or DocMan about it. They have their own trainers. I'm not allowed to train. I can give the general overview about how it should be done, but the keystrokes, they have their trainers and I can't even replicate their systems. That said, it's easy peasy. The more you do, the more keystrokes, the more quick fixes, the more F keys you can use. It is not difficult at all. One of the issues is, of course, that you have to have a dummy patient to train on. You are not allowed information governance. You have no right to be looking at anybody's records. And setting up a huge body of dummy patients to train people on is way, I don't have a system to use. See, that is one of the issues with getting experience. You can't have it unless you're in the practice. It's so difficult. And a bank of dummy patients on EMIS is way beyond my capability and my access. I don't have access to it.
So it seems like the perfect storm of how do you get it? It's like when you start when you're 17, how are you going to get experience if you can't get experience?
Yeah, well, how are you going to get a reference when you haven't had a job? Yeah. I know it's a vicious circle, but again. I talk to managers, I talk to partners about recruitment, and they say things like, "No, we need someone who can run. We don't want someone that we have to train, except of course when it's an apprentice and it's costing you no money." Right? But I say to them, "What are you talking about? You're old. You're old. Stop talking about, it was hard for us to learn these new programs, and it was, but we really had to learn on the hop during COVID, right? But young people who are interested, people who are techie, can come in and sit and do this stuff. No bother. It's not the system training you need. That's not what you need. You need the context training, the safety training. That's what you need to teach people. The keystrokes.
I just think it's funny that I'm allowed to vaccinate over 8,000 people and learn Pinnacle.
Yeah. I know, it is. It's ironic. Absolutely.
Yeah, same here, Vanessa.
Yeah.
See what happens, though, when we want you. When we want you, we want you.
Free.
I'm going to throw things out of the window. Oh, information governance. Oh,
Yeah.
It is. I know. I've worked with the NHS. It is peculiar.
Mm.
I know, and I haven't. The CCGs do request from the training bodies, and have requested from me, can I do EMIS training? I go, no, I can't. I can't. I'm not going to stand on EMIS's toes. So it is a bit of a vicious circle. It is.
The attitude is you're missing out on so many people that can bring so much more.
I know, and I also say to the GPs, I mean, they're great. Don't get me wrong. I may appear to be slagging them off a bit, but they're GPs. They're GP. And let me do the management stuff. I don't do the clinical stuff no more. You do that. I say, you want someone who's enthusiastic, right? They do not forget tech skills, right? They're important, but if they're young enough and they're enthusiastic enough, then they'll be fine. Okay. What you want is someone who likes to be with people, who has communication skills. Retail. People who've come from retail. I'm mentoring an apprentice at the moment. She's from the co-op. Right. What does she say to me? She says, absolutely loving the job, loving it. But I find it really quite difficult to communicate with some patients. And I said, why don't you explain that? And she said, well, I've got, she's 80 years old, this patient, and she calls her up and she's 20 years old, this apprentice. She's got no massive life skills. And she said, this woman is 80. She's got lots of comorbidities, lots of things the matter with her, diabetes and arthritis, but she's got a 90-year-old husband with dementia and she's struggling to go out. And I'm telling her she needs a blood pressure checked. And yeah, it's tough, isn't it?
What happens when you are the other end of the spectrum and you're not 17 and you're, for instance, I'm not 16, but if I were, I have a horrible feeling, and I hope it's not right, but I have a horrible feeling I might be hitting ageism.
Yeah, mate, possibly. Yeah, possibly. I mean,
this why?
I think it's quite ironic, isn't it? Because lots of GPs stay on till they're about 300. Yeah, very possibly. Very possibly.
So not only is that illegal under your information governance, not is that is completely illegal.
Discrimination. So age discrimination. Age is a protected characteristic.
Yeah.
So it is, yeah. Quite difficult to prove, isn't it?
Very difficult to prove.
Yeah.
But horribly, it's getting to be to the stage where it's getting to be horribly, in my mind, the only reason that is my CV doesn't stand up.
Possibly. Yeah, possibly.
Which is just a shame, and I don't think that's good enough.
Take all the dates off it, Vanessa, like the Americans do.
No, it's pro forma. The pro formas make you put in your birth date.
Yeah.
Or the pro formas make you, and they want your career history right from the year dot. You have to do right from the very first. I mean, anybody with a few fingers can work it out.
Now I know why I haven't got.
So I don't think I should be ashamed.
I'm proud. I'm proud of that. It's gone so long.
Yeah, that is interesting, isn't it? And I don't. Yeah.
How did we come to be on this training?
Pardon?
How did we all come to be on this training? I'm trying to remember back as to why I'm here.
Through volunteering.
Yeah, I mean, I did down at Peckwater. So does it come from the Camden end?
Yeah, it's part of Camden. Yeah.
Yeah, this is definitely a Camden issue.
Hannah, that was it.
Mm.
Yeah. Well, I'm sure you have. Have you put your CVs into the what's the James Wig? What's the Peckwater Centre GP practice?
Is that the bank one? I tried bank for vaccinating and that didn't work.
Yeah.
I got nowhere there.
No, I meant the GP practice, which is next door to the Peckwater. What's it called?
Oh, the Caversham.
The Cav, absolutely. So, my impression is the Cav is always looking for people, as is James Wig. Do you know James Wig? It's on Bartholomew Road. These are these massive surgeries that will have prescription clerks and will have dedicated care navigators and social prescribers, and they are massive practices. Practically, I think the James Wig is a PCN in its own right because it's so big. But yeah,
I recognise the names from the vaccinations.
I contacted the Caversham and they told me to go through the NHS website.
Oh, did they? Oh.
So you go back to the loop.
Go back in the loop. Oh, that's a shame. I don't know. I honestly don't know. As I said, we used it, didn't get very far, and then did word of mouth, which was much easier. Yeah. Okay. Well, I'm still, I'll still put a shout out for vacancies. See what happens. But the ageism thing, I'm mulling that one over, and that would be me but I'm doing sort of project work for people, and everything is by word of mouth. Okay, sorry. So I just again going back to the data world, I've talked about the NHS spine, the GP to GP. We used to choose and book. We used to make referrals that way. The referral system has changed, but it's basically e-referrals. We have something called patches, which is like e-consults, online access, and the NHS app. So again, right at the start of COVID, just before, it was all use this app, use that app. You can, whatever app you want to use, you can use. But the NHS then got on top of it all and thought, no, let's just have one, the NHS app. The rules regarding how patients can access their medical records is changing. It's going to be enacted or implemented in, it says the summer. I don't have a date. I don't know when the summer is actually. You can access it only through your NHS app online account. And you will be able to access every single thing that's in your records from the date of enactment. There's going to be a move to allow you to retrospectively look in your records, but from the enactment date, you can see every single thing that's in your records. It's a big problem for practices. Lots and lots and lots of frontline staff do not wish there to be identified in anybody's records. That's how bad. That's the state of play at the moment, which is really sad. They said it's too risky. Not that they're putting anything, down. I said, well, if it's all completely straightforward, unemotional, factual, what's the issue? But even that, there's some very not worried, but cautious, extremely cautious stuff now. GPs are used to it. Their names have always been in medical records. So we have EDT. I'll just tell you what that stands for. Electronic Data Transfer. NHS Digital used to be called something else. Was it CQRS? Can't remember. NHS Digital wants everything to be completely paperless, which is slightly funny because nothing's ever completely paperless. But electronic data transfer. So everybody within the NHS community sends electronic data to each other. Okay. We used to have scanners. We used to have, mainly women, would sit in front of a scanning machine, putting reams and reams and reams and reams of bits of paper through the scanner for somebody else to sort them electronically and put them into the records. That job has gone. Technology has wiped that job out. It's not needed anymore. I mean, scanning is still done, but not in any shape or form to the volume it used to be done. Emails, we've got the dreaded dot man I told you about, and we have, there's a whole, it's great, but it's a headache. This is, so the community pharmacy referral scheme is where we actively signpost and refer the patients. Okay, that sounds so simple. It isn't. It isn't as simple as saying, here's a telephone number, they'll expect your call. No, people like me have to keep the patient on the phone. Remember, keeping the patient away from what they want, which is the holy grail, which is the GP, whilst we put in data the reason why. Can I ask a few more questions? We have to put it into a separate system, open up a separate system to make this referral to the community pharmacy. Do you know, that's quite hassly. And the system sometimes crashes and the patient says, I'm not doing this, I want a doctor's appointment. The reason why we have to use this referral system, money, right? That's the reason. If we're going to pilot a new project, it's got to be able to be audited. Right? We've got to be able to say to the pharmacist, we sent you that patient. So it's all data and it's all going to be assessed and reviewed later. Because if we just say to the patient, phone up the pharmacy and they'll see you, there's no record of that anyway. So it can be very complex. These simple, brilliant ideas can be very complex and time consuming to implement. Right now, this moment, when I'm done with this session, I'm going to be working on the community referral scheme. That's what I'm going to do after this. Because I'm trying to give feedback. I'm trying to gather the feedback from the users and say, these are the issues we've got, and there are issues. Right. So, GDPR, General Data Protection Regulation. What's that flag? What's the GDPR? What flag is it wrapped in?
Confidentiality.
Europe.
EU.
Yeah. What happened in 2016? Yeah, the whole thing, as far as I can make out, and Pete might be able to help us, is that it's just we're going to continue with the GDPR European model, the regulations, until we don't. That's what I've been led to believe. But whether we do that or not, I don't know. The thing about everything is regardless of coming out of the Eurozone, we have changed significantly lots of things that we never used to do and we do now. There's going to be some fallout. The GP Resolution Board, which is the sort of board that's going to be looking at, it looks at the complaints and the issues we have now because of COVID, because secondary care closed down. We had no option but to look after our patients. We had nowhere else to take them, right? And there's going to be some cases against us because patients weren't treated properly or quickly enough and caused harm. The governments have indemnified GPs on that front because they have to. How could they not? How can the GPs be held responsible for a lack of care given by secondary care, which was closed? Right. So all of this has to be unravelled and talked through. And the good thing about this board I'm on, it's tremendously honest. There's no fudge. And that's because the government have already said it's going to indemnify the GPs against these type of accusations. That to one side, we've got the issue about us opening up all these channels. We were sending data across unsecured networks from the NHS out. That's all going to fall into some It'll have to settle. It'll be challenged. There will be some horrible cases, but we will have to look at where it all settles. And regardless of the EU, COVID did quite a significant amount of change. Right. So until that happens, until the government decides to do something different, do you remember 2017? I told you about that massive breach, hacked, right? So 2018, they were going to put this in place anyway, but that really clicked everybody into attention. The Data Protection Act, it is an act of Parliament, so it's a biggie. Applies to living identifiable individuals. It applies to the collection, processing and storage of personal data. Applies to both paper and computerized records. Do you remember I used to say information governance in the old days was, do you see that big bunch of paper over there? Don't take it anywhere. Stays in the that's information governance. That's what it was. It's applicable to every organisation. So GPs are not exempt. The NHS is not exempt. It applies to every organisation. These are the principles. Must be fairly and lawfully processed. It's got to be fairly and lawfully obtained. So if two policemen walk in, as they have done, into my practice and said, we just seen a gentleman leave the building. We know his name. Could you just confirm his address, please? He's wanted on a serious charge. Did we comply? They have to have a court order. You know, nice try, mate. Nice try. You know, and I'm sure lots of practices only ever want to do the best for the general public and would say, oh yeah, what's he done? Oh yeah, well, here's his number, here's his address. Nice try. Didn't work. It's happened, happens, and it will happen again. Okay. However, if they turned up with a court order, of course, we'd be obliged to disclose information. That's personal data. That's not medical data. That's personal data. So obviously, must be obtained, processed for specific lawful purposes, of course, and only used for those purposes. So when we receive requests for safeguarding, so we regularly, and unfortunately, post-COVID, we are receiving something like 30% more requests for information regarding vulnerable children and adults. It's really disheartening, really. When we receive those requests are the, as far as I can make out, the only requests that go into a GP's NHS inbox. It can be sent to a generic practice email address. However, it's one of those things that's so important it goes into the GP inbox, which is ridiculous because the GPs, you know, their NHS email, you know, they don't look at it that often, in my opinion. Anyway, but those requests we have to comply with. Part of the best practice, now this isn't a stipulation in the regulations, but it's best practice, is that we, the practice, calls the family, the vulnerable family, and says, oh, we've received a safeguarding request. We're just letting you know we're going to disclose information about you. How do you think that goes down? Yeah, not well. And then there's, you know, and we're charged with doing that. Okay, not the people who sent the safeguarding request out. So it's we need to know that we have to understand the law very much. Generally, if it was me, I'd say to the GP, safeguarding request has come in. What's your opinion on me talking to the parents and notifying them that we'll be disclosing information? And then it's down to the GP. It's down to the professional, the clinician, to make that decision, because I don't like making them. Because, you know, the GP doesn't want to expose me to any verbal abuse. And also, there's always, when you've done your safeguarding training, you'll know that, you know, there could be consequences. So some parents are very used to it and go, yeah, well, whatever, do what you got to do. But some don't. So it must be adequate, relevant and not excessive. Now I'm going to tell you the next horror story. Local, very local. And so the lady goes to see her GP, and she has terrible bilateral, both sides, bunions, right? It's so bad she's finding it difficult to walk. She needs them done. She's left it too long and it's quite urgent. So the GP says, absolutely fine. I'll get the referral to the hospital as soon as possible. Off she goes. So the GP, because this is a smart running practice, sends a note to a workflow optimization clerk. It's my sort of job. Admin team, whoever it was, and says, please do an urgent referral, bilateral bunions to X hospital. Job done. That's all the GP needs to do, because that's how the staff have been trained, the systems are in place, the templates are there ready to be used. Now, it's the policy of this particular practice to send all of their referral letters that they're making on behalf of the patient to the patient as well as to the referral unit. Right? They do that because it was they said peace of mind for the patient. The patient knows we've actioned what they've wanted done, what needs to be done. Great. Right? When she received her letter, she took this she took it as far as it could go. GMC, Data Protection Officer, she went all the way into ICO, Information Commissioner's Office, ICO office, everywhere. She took it everywhere. So the admin clerk did what they were meant to do, did what they were trained to do, and set up a referral letter, sent it to the patient and sent it to the referral unit. In that letter, right, it had not only her current medical condition, right, not only any significant medical conditions that need to be disclosed, because it's safe to disclose things, not only her allergies, not only the fact that she's on these medication, but all of her past medical history that should not have been disclosed, including the fact that she'd had 2 terminations of pregnancies and she'd had a history of sexually transmitted diseases. She quite rightly said that is excessive and irrelevant. Quite rightly. Everyone has agreed with her on every level. Now her complaint was, and she's suing them, her complaint was that they've caused her harm, psychological damage. She knows people at the hospital, she said. Whether she does or not, I don't know. You know, so this letter has passed so many, which I think is quite ironic because she has taken it to so many levels. And if you didn't want anyone to know, you'd go, oh, right. But anyway, but she's taking it as far as she can take it. And she is winning. Everyone's listening to her. Massive breach of information. It's on a need to know basis only. There we go. And who's at fault in that practice, do you think? I went in and I said, okay, so who created the templates? And they all went, oh, we don't know. It was ages ago. I said, okay, well, you've all done information governance training every year. Who's updating the templates? Oh, nobody's doing that. The templates are fine. Well, they're clearly not. This is what I'm saying about, yearly training for a reason. Things change. There we go. There's going to be a big payout. There's going to be a massive payout. So obviously personal data, it must be accurate and kept up to date. Coding. You don't want to code someone that's had, a hysterectomy when they've had a hysteroscopy, which are 2 different things. One is just having a look around, and the other one is taking everything out. So, you've got to code accurately. You can only code accurately if you've got medical terminology training and coding training. Not only do you have to code things accurately, you have to weight them. Okay? You have to put a value and a weight on everything you code. So, for instance, if I had, so I had my appendix out 2 years ago, but I have cancer and it started 8 years ago. Okay, I might be in remission, right? But it's still relevant. It's considered significant past medical history. If that gets entered into my records correctly on the correct date, okay? But if now I go and see my doctor, and there's so many things that's happened to me in the last 8 years, loads of things, haven't there? Loads and loads of things. If it gets pushed all the way down here, I go in with symptoms that could be associated with a return of my cancer, but the GPs can't see it because it's all the way down here, because 8 years, there's a whole string of things there. They're not going to see it. And let's face it, I've never met half of my GPs. They've never met me. You have to wait it. And when I say wait it, it means that, so you can see that I've had my tonsils out 2 years ago, but you can still see very significantly, because it's a significant past medical history, you can still see right at the top of the page, right at the top of the problem page, you can still see that I've had cancer. That's what accuracy means. The CQC want that in your records as soon as any incident, new change of diagnosis, anything like that's got to be in your records as soon as possible. And like I said before, remember electronic data transfer. DocMan is understanding everything we do, all our keystrokes. This job will be done for us anyway. Eventually, very soon, very soon. We cannot keep data longer than necessary. All our databases, okay, the GP to GP, if you change doctors, the information from your old doctor gets sucked in and put into your new doctors. However, your old doctor still has all that information. Every single piece of it is still there, except it's locked. And if you want to go in and unlock it for any reason, it's got to be for a lawful reason. Before you can unlock it, you have to state the reason why, and it's in your name. It's in your name in the records. So you can't just keep, it's in the old days, your paper records, well, they've gone, and so has the records. You know nothing more about them anymore. Now, the system locks, and if you want to unlock it, then you have to have a reason, lawful reason. That's why you have to do information governance training, to remind you of those lawful reasons. Right. Pete, how am I doing?
Oh, sorry, 10 out of 10. And you're making it interesting, which not a lot of people can do.
Yeah, well, it's got to be said. Yes, I have slept through some information governance training in the past. So thank you very much. That's very kind. And this is the rights of, we all have these, and these are the new rights, and they're going to be enacted and embedded as, if they're not already there. The right of erasure, taking things out. Right? This is all going to be a bit of a muddle, a bit of a mess when finally patients can access their full access to their medical records online. These things are going to come up time and time again. Patients are going to argue with us, right? And we need more help. We need more direction. We don't know what to do. We're not data specialists, right? We're not IG lawyers. Right. So this is all going to be, there's all going to be a fallout. It's going to be a big fallout. So the right to restrict processing, this has become quite difficult in some areas where the population is a little bit more involved and interested in data, especially NHS data. Some areas they're much. One of the areas I worked in, which was in Camden, we had, whether it was an accolade or not, I don't know. We had the highest rate of opt-out in any of the practices. Highest rate of patients signing to say, I do not want anybody, I don't want anybody within the family apart from a GP practice, unless I'm being referred to access my medical records. Well, that's because they were really, they were very hot, very interested, very worried about disclosure of the data. Needless to say, it was a very affluent area. Doesn't happen so much in other areas. The right to restrict processing. This is where those algorithms that work all in the back. And the accusation has been, and it's still there, but it's died down a bit. The accusation is that GPs get money on selling data or searching your personal data so that they can bring you in for something that will attract an extra fee. I hear this every year from patients. You only want me in to do my height and weight because you get money. It's absolutely true. It's called QOF, Quality Improvement. QOF, Quality, what's the QOF stand for? I've completely forgotten. Quality
Outcomes Framework.
That's it. Thank you very much. Quality and Outcomes Framework. Gosh, I say it every day and I completely forgot. And that is actually loads of data being searched on in the background, and your name pops into a list, and that list will say, this person, we've noticed this person is overweight and smokes. So this person needs dietary advice and smoking cessation. And if you get that patient in to deliver those two services, you get money. You get what's called QOF money. And that QOF, remember, we have our contract, the contract's there. QOF is on top of it. And patients say things like, that's only because you want me in for the money. Well, yeah, we're a business, haven't I said that a million times? But apart from that, isn't it good for the patient? Aren't we about prevention, trying to get better health outcomes, coaching, leading the horse to water and making it drink? But these are perspectives which we're going to touch on very shortly. My perspective is not somebody else's. So that's why we need to be very clear that when we're looking at how we use data, how we manage data, when we disclose data, when we contact patients about things that data has shown us, we do it with the cream on top. Quite a lot of patients I know refuse to come in and have their blood pressure taken. What? Just because? And the algorithm says, well, they're over 40, they need the blood pressure checked. What? Because I'm over 40, my blood pressure is fine, thanks. Yeah, no, I know what my blood pressure is. It's fine, thanks. So there we go. Right. Any questions? No. Anyone awake? Good. This is NHS Digital. So you've got NHS England, you've got NHS Health Improvement, and you've got NHS Digital, right? They're leading the way. Absolutely. So much money that's been put into digitising the NHS. Unbelievable. Little bit of a controversy, shall we say, when one of the directors of NHS Digital went off into an IT company that has a contract with the NHS. Just laying it there. I've just said it. I'll just leave it be. Right. Just a bit of a controversy there. So this is the access issue that's going to be coming in the summer. When? I don't know. I've been on 2 seminars to try and get to the nitty-gritty of this, and I'm very concerned. Very concerned. They haven't answered the questions. They're lovely people. They're really enthusiastic. They're ever so jolly, but they don't work at the coal face, right? They don't understand the issues. And again, more work, more work, more work. Okay. The NHS app will allow any patient to read new entries in their health records, right? All new online users will be given that access by default. If you've already got one like me, you have to go in and request it. I'm going to come back to that in 1 minute. Okay. It means GPs will need to consider the potential impact of each entry they enter. GPs are saying, how can we be honest? How can we be honest in the records? If we're going to be challenged. Yep, obesity. There you go. How dare you write that I'm obese? How dare you write I was anxious? How dare you write this could be, anxiety related pain. Okay, it's really challenging for all of us. We are not happy. There's a big safety issue. That safety issue. So all the GPs, you can see it. It's a chat box. Both the seminars with chat boxes. You can see question after question after question from all the GPs saying this will not be safe. Right? We will not take the chance or the risk of being accused of mishearing, misunderstanding, misrecording what's being said. The other thing is that, you know, you can have access with proxy to somebody else's records. Say it's a partner with access to somebody else. There is a tremendously difficult case going ahead with the. It's now with the. Oh, I don't know where it's got to exactly, but two married patients, divorced, 2 children. And they are using the children as a very, very horrible battleground. One's accusing the other of abuse, and the other one's accusing the other one of abuse to the son. The son's in the middle of it. It's absolutely horrible. Absolutely horrible. You know, where do we lie with things like that? There has to be confidentiality. There has to be some trust and rapport. But patients will. We're so used to being able to see everything, you know. The GPs are quite fearful of how this is going to backfire on them. So I just want to talk about the default. So if you set up a new NHS online account post the date of enactment, it's default. Fine, you don't have to do anything about it. Cast your minds back to the registration process. Do you remember I said that if a patient does not have any documents at all, we are still obliged to register them? Well, that stops there, right? If they want online access, right? If they want to have online access, they have to be verified, which means they have to come to the practice with ID. So I've already taken this ridiculous issue to the DPO, Data Protection Officer for our boroughs. Lovely man, absolutely astonishing. I'm waiting for him to get back to me. I'm saying, Steve, look, if you don't need to prove who you are to register with a GP and get NHS resources, if you don't need to say who you are, prove who you are to register, why do you have to prove who you are to get online access? This is causing a monumental row in northwest, much higher out than we are, northwest of London, where I am doing this exact. I'm trying to address this exact issue. No one. He's saying, yeah, it's really weird. I'm like, yeah, great. Can I have some assistance, please? Because there's an organisation called Health Watch you may have come across. They're very influential. They are a patient advocacy group. They have a very big ear to the CQC. CQC are listening all the time to them. The commissioners in this area, which I'm asked to help out in, have been challenged by Health Watch that says that some of the practices within the borough are discriminatory. And it's over this exact issue, which I'm going round in a circle about. Anyway, there we go. Information governance and the law. Right. Oops, sorry. So here we move on now to the happy complaints. But we have to look at it. This is how we used to do it. We used to put your comments in this box, please. If only it were that easy. If only it were that easy. It's not anymore, is it? Because we have a huge amount of profile. We've got a massive profile, of course we have, which attracts a huge amount of critical comments. Some are critiques, some are good. You know, you want someone to tell you how they feel and to understand it in a way that isn't abusive and aggressive. That's, of course, we want that. That's how we learn. But this is just some of the organisations that are watching us. Okay? We have our patient participation group. So that's made up from the patient body, generally self-appointed. So they're generally that they're representing themselves really, because they're not elected. But they do make up a valuable part of the support that the practice needs. Even if it is not a criticism, but a critique of what we're doing. We do need patient feedback. We've got the Care Quality Commission, there's Health Watch there. Every borough has a Health Watch. They are superbly influential, really. You never want Health Watch near you as a practice. No. We've got the old friends and family test that was suspended during COVID. It's back online. It's back now. And we have to start gathering information, feedback from our patients. Obviously, Twitter, that's what Robert Peston used. Very, very quick. All done. 1 million likes, 1 million dislikes, 1 million retweets. I don't know. Instantaneous. And then, of course, we have the Constitution, because if we breach the Constitution, we were in breach of our contract. And the bottom right is the Mori poll. Every year, a selection of patients are sent, apparently randomly, but I don't know, and ask for their feedback on their general practice. It's in paper form. Has anybody ever received a Mori poll? No, it's really weird. I don't know. I've received one, and I think I'm probably only one of 10 people who've received them. But apparently they send them out randomly every year to a random selection of varying age groups, various cultural groups. Don't know. It's very influential though. They ask very direct questions. Did you feel respected? That's one of the questions. Did you feel listened to? That's another one of the questions. So we have to be mindful of all of this. All of these organisations are monitoring what we do. And quite frankly, we don't want to be in anybody's headlights, really. So we just need to talk about the PPG, Patient Participation Group. Is anybody on one? In one? Okay. No. Okay. So every practice has to have a PPG. It has to meet virtually or in the flesh at least every quarter. And it should really run along the lines of any type of committee with a chair and, not membership secretary and all of that. But it's very, very, very difficult. Some practices have brilliant PPGs and there's 30 people, and some, like ours, we could hardly recruit 4. It wasn't particularly successful, but that's it. But one of the great things about certainly places like the Caversham and Jameswick, the bigger the PPG, certainly when you've got COVID clinics, the PPG really came into their own because they were able to go, they knew the local population, they knew the patients, and they got lots of recruits like yourselves. Maybe that applies to some of you, maybe it doesn't, but I saw PPGs really coming into their own. But like I said, my PPG was a pipsqueak. It was tiny, and then the people just weren't interested. I have a hand up there. Whose is that hand now?
Hi. It's mine. So can you ask to become a member of the PPG?
Absolutely.
At your local practice?
Yeah, they'll bite your hand off. Yep, they'll bite your hand off. Yep.
Okay.
Absolutely. Recruiting people is quite difficult. You have to have somebody who's really, of the patient population, you have to have someone who's really dedicated. And some people really like committees and their GP practice. So get in there. Okay. So this is Health Watch, patient advocacy. They're very good at collecting statistics and comparing one practice against another practice, which nobody likes. And they do ask again, this is from their website, send us your feedback. That's what they do. They gather patient feedback. and they act on it. They don't just keep it, they analyse it, they look at the issues they feel are issues, and they, you know, I can remember being involved in quite a substantial piece of work on learning disabilities with Camden Health Watch. It was a very positive experience, actually. It wasn't a bad one, but they initiated that because of the feedback from that particular patient group was quite negative, and so, you know, they were working with us to improve our service. Excuse me. So the NHS Constitution, here we go. The rights and responsibilities, it lays it clearly what the rights and responsibilities we have to our patients. Okay. However, at no point in any document anywhere in the NHS does it say that we have to meet the patient's wants. Here it is. Access, delivery, provision of service is based on clinical need. Triage. That's why the Mori poll asks, did you feel respected? Did you feel listened to? And did you understand what was being said? Because it's in the NHS Constitution. Obviously, consent, confidentiality. Again, do you trust your GP to manage your data? That is one of the questions. And were you given choice? See the brackets within resource. Well, I can remember, because I'm so old, Lady Di having the babies at St Mary's, one of them at St Mary's Paddington. Oh, flaming hell. Every mom wanted to have their baby at Paddington. I'm like, well, I can try. But, you know, you and the world would like the baby there. And then I think she had the second one at King Edward's or somewhere. But, yeah, I mean, yeah, you can have choice. But having a choice doesn't mean that they need to meet your request. So lots of things in writing don't really stack up in reality. And of course, the right to complain, and we have a duty of candour, a duty to tell the truth if we have messed up. And people do take the attitude, and I understand completely, well, there's no harm, we don't have to say anything. Except, of course, that trust that got fined for not, part of it was because they had no candour, they weren't honest. They went, oh yeah, thanks very much for telling us, and did nothing about it. Duty of candour. So we can, if you want, have another 10 minutes, or it's completely up to you, it's your day. Or we can, let me just see where my, yeah, we've got 8 minutes. Would anybody like to ask any questions? Or we could just plough on. How's everybody feeling?
Plough on.
Well, why not?
I'm happy to plough on if everybody just wants to grab.
I'm happy to carry on.
Yeah, great. Okay, so this is the bit where we go a bit downhill and then we come uphill again, right? So we've got to go down first and then we'll come up. Now, this is a really disheartening piece of information. So the public satisfaction with the NHS and social care in 2021, it's one of the lowest satisfaction rates on record. One of the lowest. Overall satisfaction with the NHS fell to 36%. That's quite shocking, isn't it? Don't you think? This is the lowest level of satisfaction recorded since 1997. I was trying to think what happened in 1997. Oh, did the Labour Party? No. Oh, I don't know. I'm trying to think what happened in 1997 that it was so low. But anyway, it's really shocking.
That was the last year. That was the change of government happened just after that, didn't it? So there was definitely a change in regime prior to 2000. Yeah.
That's right. I was right. Yeah. Okay. So, yeah, there's that's significant, isn't there? So there was obviously a sort of tremendous mood for change. More people, 41%, were dissatisfied with the NHS than satisfied. It's across all ages, incomes, groups, sexes and supporters of different political parties. And that itself tells you everything you need to know. Everybody. You can't put anyone into a particular type of group. The whole of the nation were very dissatisfied. Yeah, Ron, thank you very much. the United Kingdom. Let me just have a look and see what the chat says. 1997 United Kingdom general election. Governing Conservative Party under John Major was defeated in the landslide by the Labour Party, Tony Blair. Yeah.
I don't have a chat for some reason. I've looked everywhere. I don't have one. So.
Okay. Okay.
Don't worry.
Yeah. Well, I can try and amend the last slide, and I'll put my email address up there. So yes, thank you for reminding me. I should do that. Okay, so that's the state of play. So no more clapping on a Thursday. This is straight in the lowest levels for 30 years. So if I so wished, and I don't, if I so wished, I could deliver what we call customer service communication skills every single day of every week, twice a day. If I wanted to do that, I could get a job doing that. And every person I'll be training will be a member of the non-clinical teams within primary care. Nobody else apparently has got dissatisfaction with general practice is about frontline staff. Nobody else in the teams, they all get it completely right. That's the theory, that's the feeling.
Except the fee, it says it's because they can't see a GP, and that's not the responsibility of frontline staff. That's the lack of GP, surely.
Logically there, absolutely. But I'm never asked to give any type of communication skills training to any other person or profession within primary care. Now, I've had to think long and hard of that, and I do sort of know why that's the case. The case is, as I've said previously to you, is that for reasons I cannot fathom, the powers that be believe that if you engage somebody to work as a non-clinician in general practice, they don't need any training. It's innate in us, generally, mostly women. We know how to speak to people on the phone. We know how to communicate with people who are dying, unwell, unhappy. Do we? Do we? Of course we don't. When you're a GP and you're doing your GP training, you get taught a seminar in communication skills. Okay, if you ever want to see somebody, we all know brilliant GPs. And what I used to say pre-COVID is if you go to that GP and say, can I sit in with you, right? Can I sit in and just shadow you? With patient consent, obviously. And two things will happen. One, the GP's self-esteem will shoot up because they go, yeah, I'm really good. Yeah, the staff think I'm brilliant. And the second thing is, they will be on their absolute bestest behaviour. They will remember all of that training they did and had to be assessed on. They have to pass their communication skills assessment, right? They'll remember all of that training, and the person, the member of the team, will learn what good communication is. Nurses, I never got any. I didn't get any medical terminology training either. I had a dictionary. Do I have it? No, I usually have it around to show people. No Google. Had to learn it. We did not have any communication skills whatsoever, training whatsoever. It was a given that women knew how to communicate. Really? So sexist, claptrap. Pharmacists, dietitians, coaches, counsellors, podiatrists. I could go on. Paramedics. Anyone with a front, if you're in a profession, anybody who has a front-facing, patient-facing role gets trained in how to communicate. We don't. So what the 3-to-1 ratio, the 5-to-1 ratio. Sorry, there's 3 more non-clinical staff to every clinician, generally, in general practice. However, the 5-to-1 ratio stays. Every one patient that the GPs consult with, 5 will have gone through someone like me. That's the ratio. And to think that we don't need communication skills training, it's ridiculous. Not only are we not trained in medical terminology, the language of the institution we're working in, we're not trained in communication skills. It's a given. You're a woman, sit down, pick up the phone. And this is, I really do get very angry when even now when I'm talking about it. So you know, because when you look at, when you drill down into the complaint statistics, it's got to be done. Someone like me has to do it. I told you the 80-20% rule. 80% of consultations go on in general practice. That has increased by 2 million per month. Of course, we're going to get more complaints. But when you drill down, the number of complaints per ratio of contact, you know, so general practice gets a small amount compared to what's going on in hospitals and the ratio of patients that they see compared to complaints. Of course they do. Much more harm comes in secondary care. It's all invasive. It's all, you know, traumatic and dramatic. General practice, we're not really like that. The difference back between general practice and secondary care is you can get us. You can see us. You can stay on the phone and get us. You can walk in. We're accessible. You can't walk into the Royal Free and go, oh yeah, Hamilton is my consultant. Can I see him, please? Yeah, I've got half an hour. You can walk into a general practice, now our doors are open, and talk and abuse the frontline staff. It's accessibility. It's volume and accessibility. Now, I'm not saying everybody who comes in is angry and anxious, but we've got the lowest rate of satisfaction. These patients, our patients, us, we're human, we are frustrated. Okay? And to continually expect our staff to be trying to manage this frustration and anger without training really upsets me. But 40% of the you see, 40% doesn't seem that high because 60% is about other things, but 40% of the complaints that come into general practice are about the attitude of frontline staff. They are. You know, the other 60% is actually right. It's about not being able to get a GP, not being able to get a face-to-face appointment, a delay in referral. Well, we've talked about that. A delay in results, getting results, not being referred, that type of thing, which is all clinical. But when it's 40%, you know, if you've ever had a complaint made against you or about you, it's really quite upsetting. So here we are. We have to keep our patients safe. That's number one, right? And I say this to all the delegates who come on, you know, who do the training. Sometimes you have to be very self-reflective and say, maybe this isn't the job for me. You do. It's a bit like being a chaperone. Some people don't want to do that. I can understand that. So, you know, we really do. If we want to be in general practice, we have to want to make a positive difference to somebody's health. We want to be, you know, we want to help and change. It's what we want to do. Or maintain, you know, if someone's healthy, great. Right? But if they're not, we want to help them get a better health outcome. However small part we play in that, we are caregivers. Right? Obviously, we need to comply with all the laws. We cannot discriminate. We have to comply with the CQC compliance. And remember, we are under, you know, we're under a huge amount of scrutiny, aren't we? Lots of scrutiny. So this is the little thing I'm going to gift you. How about that? So this, we can't really, you know, change somebody's behaviour unless you physically block them. Right? Can't, you know, that's not what we're about. The only thing we can really do is change our own attitude. That's all we can do. My attitude affects my behaviour, and if I don't change it, it'll just do an ever decreasing circle, and my attitude will affect somebody else's behaviour, which will affect their attitude and their behaviour. It is a circle that is catching. I know this. I've trained myself, a bit like the ship and in the resilience. I've trained myself in this. It doesn't come naturally, right? The scenario, real scenario. So get up in the morning. I made a concerted effort to walk to the practice. It's only a mile away. I have a parking space and it's just ridiculous. What am I doing? And certainly with petrol. So I thought, no. And I have quite a nasty complaint to deal with, which I've been putting away and putting off and putting off. And I thought, you know what, Monday morning I'll get up earlier than I usually do and get in and spend 2 good hours, bright, fresh, oxygenated blood sitting there, and I'll get this out of the way, and so I can start the week with this burden off my shoulders. So I get up earlier than usual. No milk for my coffee. Why would anyone think that I would like milk in my coffee when they had the milk in their cereal? So that annoyed me, right? The crew, the family that live here, didn't think, oh, maybe we should save some coffee, right? That's number one. Number two, one of the lads couldn't find these things, you know, these things, toggles, USB sticks. I couldn't remember the name. And it was in a bag and he needed it. And did I know where the bag was? Yes, I did. Well, it wasn't there where I thought it was, but I found it. It wasn't in that bag. It was somewhere else. So that took another, I don't know, 4 or 5 minutes. No milk, 4 or 5 minutes late. And I'm annoyed now. I'm annoyed and I can feel my annoyance growing. I stand outside of the door. I walk, close the door. I walk. There's somebody else in the house, so I didn't have to lock the door. So I walk over to the bus stop because I'm thinking, well, I could really walk quickly or I can just hop on the bus. Realise at the bus stop I have no phone because of this kerfuffle with them. So I had to come back, bang on the door, let me in, get my phone off. And now the bus is late and I am late and I am so angry. None of this is my fault. I get to start to walk towards the practice, and as I'm walking towards the practice, I'm in such a foul mood. The door opens, a patient comes out, and there is my fabulous colleague sitting or standing behind the reception desk, big smile on her face. And I knew the minute I walked in there that I could affect her whole day and the day of the team, the team, the whole dynamic. Because I really did. I wanted to go in and say, right, morning, yeah, did you have a good weekend? Great. Is there milk? Because I didn't get any milk this morning in my coffee. There is milk, great. So listen, I'm going to go upstairs. Don't interrupt me. 2 hours, horrible complaints. I really need, I don't want any interruptions. You just tell the rest of the team, don't interrupt me. I'll see you later. Now, what would have happened? She'd have been, oh my Lord, she's in a bad mood. She'd have gone straight into the admin room. God, she's in a bad mood. Don't talk to her. I don't know what happened. What's the complaint about? Is the complaint about me? You know, oh my Lord, yeah. What happened on Friday before I left? Is there something going on I don't know about? Then they've all gone. I walked in and I said, good morning. Did you have a great weekend? Good. I had a great weekend too. Thanks. So I'm just checking. Do we have milk? We do, fab, because I didn't get any and I do need some coffee and I'm woof. You know what I'm like without my coffee. But I'm also going to have to do the complaint. I'll tell you about it later. Don't worry about it. It's going to take me 2 hours. Would you just tell everybody just to give me that 2 hours? I'll talk to everyone later. Right, great. Thanks. See you later. My attitude affected my behaviour, which affected her attitude and her behaviour. You can do it. I cannot change anything, you know, except how I feel. And that is what we have to take with us to work every single day. We are listening to complaints every single day. Small, big, large, it doesn't make, you know, horrible ones. We get it all the time. You cannot get sunk. You cannot take when the nurse said, I can't stay in this grief and this anger and pain. I have to go to the patient that needs me. They don't need me, only half of me. They need all of me. You know, we can't, you know, don't let the water sink you down, which is what happens. It happens in work, out of work, in your families. Right? This is basically the Batari cycle. It's to break the cycle of negativity. And the other thing is the ironclad beetle, inner resilience, people, inner resilience. So this beetle was found. Does anybody watch Ice Road Truckers? I think it was a lockdown guilty pleasure of mine. It was amazing, all these great big ice trucks going up to Canada, up to the coldest places in North America. And they came across this phenomenon because it's a relatively new area of these black lines going across these icy roads, and they'd roll over them. These trucks had come out and just roll over them, and they'd look in the mirror and they'd all bounce back up, and just none of them got squished. They all just got up and wandered off again. So there was a load of research done, and basically they flatten out. They feel and read the pressure coming towards them. The truck's a mile away. They know that. They'll keep walking. It's half a mile away. They know that. They can feel it. They're built to feel the pressure. Exactly know, and they're so attuned to when it's a foot away. It's half a foot away. It's an inch away. And the minute and only then do they unwrap their body, flatten themselves out. Truck goes over them. They bounce back up and run off. Completely conserved their energy because there's very little food. Inner resilience. They're very complex but quite simple creatures. That's what we have. That's what you have. It's sort of what you have to do at work sometimes when you feel the first conversation goes okay, the second one goes okay, the third conversation with the patient goes okay, the fourth conversation, the patient's already waited 30 minutes on the phone. Doesn't even say good morning. The fourth patient says, you took your time. Where were you? Well, I was actually answering the phones to patients like you. How can I help you? You have that 6th, 7th, 8th, 9th, 10th time because the patients, it all stacks up. So it does get to you. It does get to you. Yeah. So what we have to do is just remember that, this is the training that we do. Good. What makes you good? When you've had good service, how do you feel? I was in. Sorry, Patty.
Oh, I was just going to respond and say, it probably makes you feel very good about yourself.
Yeah.
If you had good service.
Yeah, you feel cared for, don't you?
Yeah.
They listen to me. I bought 2 Hoovers. I only went in to buy 1 Hoover, but I bought 2 Hoovers. 2 Hoovers. And yeah, I don't know what was that about, but I thought, and this man in John Lewis, right? My mate, when I was, when we were leaving school and I went nursing, and she went to John Lewis. John Lewis sells you Hoovers. She spent 2 weeks on an induction at John Lewis, 2 days on customer service training. Do you know what I got? Do you know what my colleagues got? Up until the other day, absolutely zero induction, apart from there's the coffee, that's the fire alarm, that's the fire escape, and 0 on customer service. See, I can get very annoyed about this, but I shall rein it in. Yeah, this man told me everything I wanted to know about. The first guy I asked, he said, "No, I'm white goods," and I'm like, it's interesting. Washing machines and fridges. I don't know anything about Hoovers. Go to my colleague. He's the Hoover man. Oh, right, sir. And I was really, really happy. Spent a lot of money, but by God, were those 2 people trained in customer service? Oh, yes, they were. Yeah. And we're in the business of health. We're in the business of care. And the 5-to-1 ratio, it's, forget it. Unless you're a clinician, why train anyone? Right? So, key characteristics of excellent customer service. Communication, right? You listen to me, right? You ask me questions if I haven't explained myself, right? And then you double check. You say, did you say you wanted a Hoover for the stairs or for the carpets on the ground floor? Right. Or you want both. That's why I got 2 Hoovers. Consistency. This is where it all breaks down in general practice. I told you there has to be 1 or 2 acceptable methods of requesting prescriptions, and whoever is taking those requests knows that it's those 2 ways of requesting a prescription only. Right? Because otherwise, inconsistencies. The patients will say, hold on, I phoned up the other day and I was allowed to request it over the phone. Why are you blocking me? Well, I'm not actually. I'm following the process. I'm following the agreed procedure. It was Madam who didn't. You know, people feel that they are being pushed away when that happens. Got to be flexible. We are flexible. I know that. The patients don't think we are, but there's a lot of trying to fit people in and jiggle people around that the patients don't see. We are flexible. And competent. This is what this is all about, and I'm delighted that the GP Forward View are looking at the competency skills that the non-clinicians have. We are looking to upgrade ourselves. Okay, so we've got to be courteous, respect, trust, respect. That's what people want. That's what our patients want. That's what I want as a patient. I want to feel that the people I'm talking to actually want to help me genuinely. And also, there's a degree. If you remember, I said that the more hands a piece of paper goes through, the more errors that will occur, because it will be no one's ultimate responsibility. And that's the same with taking phone calls. It's that thing of, being passed around and passed around. When you say, we say things like, yeah, the doctor will call you back when, well, I'm not actually sure, but I do know you're down on his list for tomorrow or Wednesday. Yeah, just giving more information. Yeah, I'm not sure is an okay response, because we're not, are we? But yeah, giving the patient more information, being responsible. So this is basically the premise. You have to take care of all the patients as if they're your own relatives, even the ones you don't like, right? I mean, even the relatives you don't like. So obviously, positive and friendly. When you're getting that constant knock, it's quite difficult. It is difficult sometimes. The indifference, the amounts of complaints that I have read that say the frontline staff couldn't have been more indifferent to my request. Quite a damning description. And I read, when I'm with delegates who are working on frontline, I do read letters out. And they are quite, yeah, and then most of us are quite ashamed of our behaviour, but it comes because we've never been taught to do anything other than just respond, react. That's what we do. We react. We don't take the time to respond and think about things. It's all this pressure on us. It's wrong, absolutely wrong. And obviously we want to be treated as an individual, not a number. And this is what happens. These are our patients. They turn up to us, and sometimes we even go into work like this, confused. They're worried. They're caring for people that are dying. They could be dying themselves. Perplexed. The amount of anxiety and depression has skyrocketed. And they come to us, and we have to understand difficult behaviour. Is it? Because I know there are absolutely justifiable times when patients have reacted, and they've been justified in doing so. Anybody think of a time when behaviour displayed by patients is justified? Negative behaviour?
Yeah, I got an example. I was working in a vaccine clinic, and it was back in the days when we had massively long lines of queues outside, and we had a patient came in who was quite aggressive and upset that she thought she'd been racially profiled by the person on the door checking her in, because they only talked to her boyfriend and assumed she didn't speak English. And literally all we did is sat down, talked to her for a couple of minutes, reassured her and said, I'm sure it's not the case, ran her through what the complaints procedure was. And she didn't want to take it any further, but she was 100% justified to call that out because it was wrong. But it was probably due to the pressure of having 1,000 people come through the doors in a day.
What a great example! What a great example! And that you also described exactly how you contained it. I don't mean contained as in restrained. I mean contained the situation. Whoever was dealing with it was responsible, took responsibility, and didn't, say, oh well, that's the way it is, but listened, empathised, and agreed, And it worked out the best because A, she obviously felt better that she was listened to, and B, no complaints. But weren't those? Gosh, I've forgotten those times. When there'd be like, I don't know, it felt like 400 people all outside, going all the way round. I remember all the way round. I couldn't find the end of the queue. Oh gosh, weren't those hard times? But I think there are times hanging on the phone for 30 minutes. I'm not surprised patients are angry. Being told to call back at 8 o'clock in the morning for an appointment which doesn't exist. These are all things that happen in GP practices if we're honest. And what happens is we just let it go. We just let it go because it's easier. Because we talk to the GPs about it. They said they haven't got time to review and redesign the appointment schedules. We have to slow things down. We have to. We are coming out of the other side, and we do have to take a good hard look at how we provide our appointment systems. Because as far as I can see, and my experience is telling me, and it's not just anecdotal, I go and, well, it is anecdotal, but I talk to people, managers, and they say it's just getting worse. Rula, did you want to put your hand up?
Yes. I took communication courses and everything, and they stress a lot about empathy.
Oh, yeah.
Yeah, because especially the patient who suffer, he needs to feel that somebody is understanding him and helping him to get his way through.
Absolutely, yeah. You want to feel like somebody's on your side, Empathy, that's exactly how we move patients. We can move patients into a better state, whether that be psychologically or things like eating less, eating healthier, drinking less. That's exactly what we want to do. We want the patient to trust us so that they are happy with the advice or the directions we're giving, even when it's not what they think they need, even when we can't meet everything that they want us to do. Even though we haven't met their exactations, we get a happier result. It's about empathy. Absolutely. Vanessa, you've got your hand up.
I just wanted to know how you thought that this was going to be resolved. I've got two girls, one's doing A-levels, one's doing GCSEs at the moment. And my youngest, who's doing GCSEs, wasn't well yesterday. And I asked the school what the protocol was, and they said, well, if she's really not well, then we have to, nationally, is required to have a doctor's note as to why she's not well, and that has to be given in this morning, for instance, so that she would be assessed rather than sit the exam. And my response was, I just dosed her up with Calpol and sent her in.
Sent her in, absolutely. That's hard, isn't it? It's difficult. It's a bit of book passing, So she's very unwell, and she has to prove it, and the only proof is to have a doctor's certificate. And the doctors, we you know what? That's that's taking up the doctor's time and all of that sort of stuff. And of course, there's probably a charge for that because it's not part of the contract. But all we want is for your daughter to do well in her exams and not be stressed. There absolutely has to be a better round robin of how to do this. But yeah, I don't know. I haven't got any answers. I love to sit down and we talk things. Let's try and talk. Let's try and reflect and then see how well we can do. But there's quite a lot of closed minds because of the pressure. And I've got to go back to the patients. Which is, I understand that, but we do, if you always do what you've always done, you're always going to get what you always got. You have to stop somewhere and reflect on it. But I suppose that's maybe perhaps that's for the primary care networks to do, because they're slightly more detached from the coal face, if you like. Sarah, did you want to say a few words?
No, just sometimes difficult behaviour, because it could come from somebody who might be on the autistic spectrum, for example, or someone who suffers from anxiety. If they've waited a long time, they're going to start to show behaviour that would look difficult. So we'd have to be trained in how to deal with that.
Absolutely. Learning disability training, that is part of the mandatory collection of training sessions. You're absolutely right. The unique bit, I talked about embracing new technologies going forward, even though it's doing us out of jobs. The element that we have is that we're human. The element that we have is that we know our patients. We do, if you've been around long enough, we do know our patients, but we have the complete set of medical information in front of us when the person calls or when we see them. And there's alerts on patients' records, making sure that whoever's looking knows this person has a disability, a vulnerability, a safeguarding issue. Excuse me. And that puts us in a very unique position. They don't know them at the hospital. The pharmacists actually don't know the patients. Everybody we refer the patients to know only what we've told them, and only then can they, with patient consent, can they access the rest of the medical records. You're right. We do. We need training. We do absolutely need training. And it's hard fought, very hard fought. When we are looking at our patients and we're trying to help them, a bit like the beetle, the diabolical ironclad beetle, we have to read the pressure. Okay, and again, we have to understand what type of behaviour we are looking at. Okay, is it frustrated? And we've already said that behaviour very often is justified. Right, for various reasons. And if we don't manage the frustrated patient, if we don't manage with our communication skills effectively, it could just drop into one of those other two types of behaviour. The nuisance behaviour is when the patient just becomes stuck. Nope, I don't want you. Put me an appointment. Baby, gets into the groove and isn't coming out of that groove. Abusive behaviour we don't tolerate. That's a different thing altogether. But nuisance behaviour, what we're trying to do is get the patients back into neutral. Wouldn't that be lovely? But certainly not nuisance. And if we're staying frustrated, at least it's not nuisance behaviour. This is the thing. We have to read, and then we can then we can reset and go forward. Try and make a positive difference. So that just understanding which level of behaviour just takes a nano moment, but we know exactly where we are, what behaviour we're dealing with. It is all about us. It's very difficult to change somebody else's behaviour if you are reflecting that bad behaviour back. Okay? It's just going to go in an ever decreasing circle. And it's about perspective, isn't it? Who sees a young lady? Who sees an old lady? I could only ever see a young lady until I taught myself to see the old lady, and now I find it difficult to see the young lady. It's very aggravating. Old lady, young lady, Who sees something completely different?
I twiddle between the two.
There we go. Yeah.
I can see the young lady.
The old lady.
The young.
Oh, yeah. Anybody see the old lady?
Young lady.
Yeah, a young lady.
Yeah, so young lady is the default. Interesting, one of you could see both. I can only ever see the old lady now because that's all I can ever see. But yeah, we look at things differently. We see things differently. We feel things differently. If anybody wants to find the old lady, she's hunkered down into a furry black cape, and the slash of the young lady's choker is her mouth. And then above that, she has a nose, and you can see her eyelashes and a small outline of her eyes. I don't know if you can see that now.
Yeah, I can see that now. Yeah.
Yeah, you see it because I've taken the time to show you a different perspective. Yeah? And this is obviously just a picture, but when we're in the real world, this is very much how it appears, both looking at the same thing. The guy on the left, that's a 6. Guy on the right, no, that's a 9. Guy on the left, that's a 6. You put that into, if I look out that window, I've got the primary school and a car in front of me, and I'm looking out that window, I've got a shed. Right? I'm still in the same place. This is what happens. A patient calls up, can I have an appointment, please? The administrator, yes, I've got an appointment Tuesday at 11 o'clock. The doctor will call you. No. The patient says, I want an appointment. Yeah, I've given you, it's 11 o'clock. The doctor will call you. No, you're not listening to me. I want an appointment. It is an appointment, except it's not the appointment the patient wants. The patient wants a face-to-face. The receptionist has been told all appointments are triaged. So, when I talk about wanting very much more involvement with the patients, this is exactly what I mean. Yeah. How many times have I heard, oh yeah, well, I don't want that appointment. I want to see the doctor. No, I want to see the doctor. You telling me I can't see the doctor? Well, actually, technically, yes. What I'm telling you is, until the doctor says you can see them, I can't book you in, but I can get the doctor to call you. Sarah, the picture, old lady, young lady. Oh, was not available. Oh, really, Sarah? Couldn't see either of them.
No, I didn't see it. Doesn't matter. I got the picture in my head.
Oh, right. Can't see either of them. Well, yeah, there we go. There's a perspective. How long do you think it takes?
What I mean is I didn't have them on my screen.
Oh, sorry. I thought you just. Oh, there you go. You can see that now?
No, I can't see it, but don't worry.
Oh, righto. Can you see that one?
No, nothing's coming up. I don't know why.
Oh, you might have to. Can everybody else see the screen? Yeah.
Yeah.
Yes, okay.
Oh,
Yes.
I think that might be. Unfortunately, Sarah, I think you might have to maybe log back on again. I'm not quite sure.
Maybe.
Yeah.
I've now logged on my phone
Yeah.
as me, and I can see the chat, whereas on my computer it insisted on putting me in as a guest.
Oh,
I hate Teams.
I know. Me too. Tell me about it. Yeah, I know. So, sorry. So if we're thinking about first impressions, how long do you think it takes to create a first impression?
Probably 7 seconds.
7 seconds isn't a very long time, is it?
No.
30 seconds.
7 seconds is
Yeah,
basically
7 seconds, I think.
Yeah. If you've been on hold for 30 minutes, you've blown that 7 seconds. We, the practice, the team, the system. It's very difficult. How long do you think it takes to change your first impression?
Only when you recognize a positive change.
Yeah, probably. But you know what? the patient phones back and again, or goes to the reception and is held in a queue again, and they're 40 minutes again. We get one chance to create a good first impression, and it's quite, you know, and what will happen is, you know, people remember your voice. People, they remember my voice because it's not local. Yeah, I say, oh, I remember you. No, I won't remember them at all until I see the name, possibly. Yeah, because I'll have spoken to at least 2,000 people in between when they called and when they called back again. It's really hard. We really have to do some hard thinking about how we are, you know, going to deliver our services, because we aren't making a good impression at the moment, and certainly the survey shows it to us in all glory. If I showed you, if I said, oh, Mrs. Jones, here's your doctor will see you now, and I showed her the guy on the right, I'm sure he's a lovely man. You know, you can make 11 impressions in the first 7 seconds. That's why the 7-second rule is there. Your eyes go bum, 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 and your head connects it all in and go, ooh, or, yeah. Guy on the left looks like a doctor. Guy on the right doesn't look like a doctor. Remember, don't judge a book by its cover. Right. So we know the communication chain, 2 parts, listening and talking. Simple as that. Listening for success. That is exactly what we want to have big ears all the time. Look like you're listening. The social presence theory, that's what it's called. And I just want to show you this because I read this. There's a guy called Gary Neusner. You can tell he's American. He was director of the FBI for about 16 years, and he's written some amazing stuff on the psychology, but empathy. And like Rula said, empathy is the key. Listening and empathy, showing empathy. So this, obviously, he created this for ultimately to get hostages freed, you know, alive, obviously, FBI. But this is the ultimate in the listening, in listening and showing empathy. Now, I know we're not trying to release hostages, but the premise is exactly the same. This Gary Neusner guy, fascinating. He said that he has so many applicants for these positions to be hostage negotiators, and he says they're all hot shots. They're all straight out from Harvard and Yale and Princeton, and oh my goodness, they think they're brilliant. He says they know everything. He said except how to listen. So they stand at the bottom step and they jump right up to the top step. They can't be bothered. It's too much like hard work to go through the rest of the steps. He said, and that's what young guns do. That's how you get killed. That's how your hostages die. Because you know more. You display arrogance. Not arrogance as in, hey, look at me, I'm brilliant, but arrogance, no empathy. When you have no empathy, you have a void or you have arrogance. Right? And unfortunately, a lot of the times, people who don't understand, people with learning disabilities or people with some personality traits that sit quite into sort of mental illness, they misjudge, they misplace being a void, being emotionless with arrogance. Look, they aren't even talking to me. That's why we need that's why we need training in learning disabilities, because I know that, you know, before I did the training, I thought, oh God, they're so arrogant. No, they were in a space that is a void, really. They're not showing anything. And I used to think that was arrogance. Anyway, I digress, but you're right. Whoever said we need training, we need training. So this is it. This is exactly what we should be trying to teach our staff and ourselves. Active listening, bump, big ears. Active listening, listening to their side and make them aware you're listening. Socially present, physically look like you're listening. Empathy, yeah, it's understanding their perspective, saying, oh, I understand, you know, that, you know, it's a 9, no, it's a 6. That's if you just keep doing that, you're not going to get anywhere. Okay, empathy. Rapport builds trust. When you have empathy, you get rapport, you get trust, you build trust. Once you have trust, just like the health coaching, you can influence behavior. And obviously that's how, you know, the ultimate thing is to get behavioral change. Brilliant example, nice one, I think, for all of us health coaches out there. Okay. Conversation is a dialogue, not a monologue, although sometimes I do sit here talking to myself thinking, oh, I think, is it just me? But no, thank you very much. I'm enjoying all your feedback. Do you think you're good listeners, guys?
Yeah.
Yes.
Okay. Yeah. Got a few thumbs up there.
I've learned to be a good listener.
Yeah. Well, you have to with my mum because you can hear her about 6 streets away. Okay. I'll ask you a couple of questions. How many animals did Moses take onto the ark? Anyone?
Sorry?
Did you not hear the question?
No.
Sorry. Okay. Anybody else hear the question?
Yep.
Yep.
Oh, yep.
Any answers?
No, many, I should think.
Many.
But we know it's an even number.
2.
Okay.
Yeah.
So I'll just repeat the question because Rula didn't hear it. How many animals did Moses take onto the ark?
None.
Not
None.
Moses.
None.
It's Noah. It's Noah.
See? It was Noah. Come on, guys. So what did we do? What did you do there? I'll tell you exactly what you did. Okay? You jumped. Yeah. You jumped to the end. Didn't go all the way through, right? And that's what we do. You latched onto a word, an unusual arc. We don't use it all the time, do we? An arc is always associated with Noah and 2 by 2. So you went backwards. Okay, here's the next one. If a plane crashed on the borders of France and Spain, where would the survivors be buried?
In their own country.
Nowhere.
And why is that?
Well, because you don't normally bury alive people.
See, you see, those of us who are around a long time, the minute you hear a patient's voice, you can go, you can have an inner little sigh because you have already decided wrongly what you've expressed an arrogance. I know what this patient wants. Oh, not this again. Wrong.
That is really scary, actually.
Yeah, it happens all the time. Oh, I think the question is interesting. Okay. So is that Lou? I'm sorry, I'm not sure. You're having technical issues. So I will actually send everybody this my presentation, so don't worry. But yeah, the question was a trick question, and it was how many animals did Moses take onto the ark? As Moses didn't take any because it was Noah. And the second one was if a plane crashed on the borders of France and Spain, where would the survivors be buried? Well, I don't know who was burying them, but we don't bury survivors. Okay. And that's, we have to, get into the groove, if you like, of understanding, hearing and listening. They're two different things. Here I am talking to you, talk. If over there a vase fell onto the floor and crashed, I'd be talking to you. I would hear it because I have no option. I'm not deaf. I have no impairment. It would be accidental. I would hear it. It's involuntary. I can't stop it, and it requires no effort. I'll carry on talking. There'll be a crash. I'll go, oh, David, that was a crash, because it was involuntary. Listening, on the other hand, is different. Listening is focused. It is voluntary. I am trying to actively listen to you. I'm showing it. It is intentional. If there were two people over there talking, and they were talking to each other and not me, and here I am working, and my ears prick up because they hear something. I hear a name. They're gossiping. Right? They're gossiping. Oh, did you know so-and-so did so-and-so? And I'm like, oh, so now I'm still looking over here, but I'm really, really trying to listen in on that bit of gossip and not show that I'm trying to listen, because clearly they don't want me in the conversation. But that's the difference. Hearing is voluntary, effortless. Listening, you have to really try, right? How many times in rows you're not listening to me? I am. I hear you, yeah, but you're not listening to me. That's what we've got to do. So actively listen. And these are the things that happens when we have an arrogant approach. Right? We make assumptions. Someone said, sorry, I missed who it was. That's a bit scary, isn't it? Absolutely. Just like the email from the patient who ended up with sepsis, the assumption, right? Here's a request for repeat medication. The acutes have been given. You know, I'm making an assumption that this is absolutely fine. It can wait. You know? We skip to the end, and we've judged. That's absolute arrogance, isn't it? We can have an opinion based on what we've been told, but you can only make that opinion. You can only offer a suggestion. You can only be flexible only when you've understood everything. You've got to get to the end. Yeah, boredom. That's another word that comes up in loads of complaints. Indifference and boredom. She sounded really bored. It's generally a she, actually. She sounded really bored when she was talking to me. That's not being socially present. Right? So agreeing but not understanding, that's just, words. Nah, yeah, really? Yeah, I'm sure that's the case, yeah. And the other thing is working out why they are wrong and you are right. That's clearly arrogance. Clearly arrogance. It's how you say it. Of course, we cannot give the patient absolutely everything that they would like. But by saying here's an alternative, we have to say it in a way that shows that we care. Right? It's not like, no, off, can't do that. No, you can do this, can't do that. Right? It takes time and energy. So the listen is the acronym here. Look interested, involve yourself, stay focused, test your understanding. So one of the ways that you can build trust is say, oh, did you say that you weren't able to have appointments between 4 and 5 because you had a school round to do, or you had to do something? Okay, great. Just checking. Is that on Monday, Tuesday, but not on Wednesday? Because I've got something on Wednesday for you. Great, lovely. Well, simple little things like that show that you have listened. Yeah? Evaluate what is not being said. Neutralise your feelings. That's quite a big one, because we have quite intimate contact with our patients, and sometimes we can build opinions that we don't break down. That's wrong. Everybody has to be treated, without us blocking them because we have emotional feelings against them. It's quite difficult, but it has to be done. Equality of access. Evaluate what's not being said. So during lockdown, I took a call, and we were having connection issues, and the callers kept dropping out. They'd phone back even more wild and angry. And so we'd be going, hello, oh, there's no one there. And the patient would have to phone back. It was the system. The system was just rubbish. And I took a call, and I said, hello, can I help you? And I knew somebody was there, but I didn't go, all right, there's nobody there. I knew someone was there because I could hear somebody. And an instinct kicked in. So I wrote down the number because it had caller display, but it wasn't in our system, so I didn't know who it was. I said, can I help you? Nothing. And I could hear some snuffles. I could hear breathing. I said, can I have your name? Nothing. I said, okay, You can talk to me when you want to talk to me. I'll stay on the line. Nothing. A few more minutes and the phone went dead. I'm like, well, I don't like the sound of that. I really don't like the sound of that. So I took the number and I checked it. It was a live number. And I went, we have to have safeguarding leads in each practice. So I went to my safeguarding lead and she said, what do you think? I said, oh, I think it's a woman, and she's phoned up and she's not able to talk to me, and I got a bit freaked by it. And so she called the number, and it was a patient, and this patient is being abused physically, domestically, and she's been put into a refuge. Evaluate what is not being said. So when you talk to your GPs about the easiest patients to consult with, they will tell you, who do you think is the least favourite person they choose to consult with? The person that they can not really communicate well with. What sort of person do you think that would be?
Do you mean as in a patient? What patients don't they communicate well with?
Some people usually say arrogant patients who know it all. You know,
I was going to say Miss Google.
I was just about to say, Googled it. They Googled it. No, it's really interesting. The patients that they feel that they can help less are ones that don't say anything. The quiet ones, those ones I told you that sit in the middle of that sort of void. So they're not full of this, and they're not, yeah, I'll do that. They're not compliant. They're not arrogant. They're the ones who say nothing, very little. Very difficult. Very difficult to try and find how to help someone if they don't talk to you. It's interesting, but of course they've got themselves to the GP. They do want care. They do want help. It takes all sorts, you see. Yeah, GP practice puts you in contact with absolutely 100% of humanity in all its forms. Apart from dictators, I don't think we've got any. They're all on a yacht somewhere. So, tips: mouth shut, listen more, concentrate. Who's behind the mask? Can everyone see this? Anyone?
Number 2 looks like Simon Cowell.
Number 2 is Simon Cowell. You can tell, can't you? It's those trousers.
I was going to say it's the moves.
Yeah. Sorry. Absolutely.
I was going with the trousers personally, but
yeah, you can tell. You're absolutely right. He's got them right the way up to underneath his moobs. So anybody number? I'll give number 4. Anyone?
I can only see numbers.
Oh. Well, yeah, I'm not sure what's happening there.
Okay, don't worry about it. Don't worry. It's probably my phone.
Number 1, anyone? The guy on the bike?
No, I can't tell any of them.
How interesting. This is what's been happening to us, remember, behind masks. So number 1 is Arnie Schwarzenegger.
Never would have got that.
No, I know. And I had to really stare at it to see it. Number 3 and 5 were in the most popular sitcom of all time, an American sitcom.
Number 5 looks like The Rock, the actor.
I don't think he was in Friends.
No, okay, I'll rescind that comment.
Matt LeBlanc then. Matt LeBlanc.
And who's number 3?
Jennifer Aniston?
The other one.
No, the other one. Monica.
Yeah, what's her name? It's completely gone from me. What's her name? Oh, it's Monica. Anyway.
Yeah.
How annoying. I thought I don't need to write these down because I know them. So it's Monica out of Friends. Number 5 is Joey, Matt LeBlanc. And number 4, Robbie Williams. Robbie Williams. Yeah. That's quite hard, isn't it? To check, see who they were. And Monica's got 2 masks on. You're never going to make any facial awareness out of that. So as old Churchill said, jaw, better than war. Keep talking. Keep offering suggestions. I mean, I'm I mean, I've bored patients into submission sometimes because I've just said, oh, no, what about that? And they go, you've said that before. And I said, I know, but should we try it again? So jaw, not war. And this is the really important thing. Empathy with social presence. You know, you have to be in the conversation. You know, it is an art, and you've got to train yourself. GPs have to do it. They have to really look interested with every person who comes in and sits down. You know, so that's what we sort of have to do, even though we, you know, we can tell if people are listening to us without us seeing them. You can tell on the phone if a child or a partner is paying attention or not. So if we think about communication, how we communicate, it's generally put into verbal and non-verbal boxes. So if we're going to put in a percentage about the one that's most influential or the most impactful, then where would you put 33% against body language, the tone, or the words? Which would you put a flat 33%, or would you load up body language 90, tone of voice 5, words 5? How would you split 100% across the three bottom boxes? The most, giving the most weight to the one that has the most impact when you're trying to communicate.
60% body language and 30% tone and 10% words.
That's interesting. Yeah, very high in the body language there. And the second one would tone and even less the words. Yep. Yeah. Anybody else?
I would agree with that. It's very, very high on body language.
High body language, yeah. Yep, we're agreeing on that. Absolutely. Only 7% of the impact of words is just 7%. The vast majority, as you rightly said, body language. Body language. I mean, what is ballet? What is dance? It's a story through physical movement. Absolutely tells so much. Movement. Yeah. And the word 7, the tone, how you say something, 38%. Not as high as body language, but still very significant. You know when you're playing with a baby, there's you usually don't say proper words. You'll just say nonsense. Nonsense, but you can make babies laugh by saying nonsense because of the tone of your voice. Yeah, and because you're wiggling your hands. The words mean absolutely nothing, but the expression, the tone of your voice, that's giving a message. What's been happening is we've been behind masks, and that has really impacted on our ability to communicate with each other and to be understood and to gain trust and to show empathy. It has been difficult. Look at how you take the physical bit away and the tone of your voice reaches an astonishing 84%. And this, of course, is what we're doing on the phone. So getting the tone right. Okay? And this is what's missing. It's called the Duchenne smile. So we can't see this when we've got masks on. I mean, with Monica, God, what's her name? She had 2 masks on. You couldn't see anything. Right? All of these lines in our faces, the smile that we make, we can see none of those things. All of that messaging has gone. So we miss the obvious body movements. We miss all those signs, but equally other things come into maximum play. If you're speaking to someone and they're yawning, what does that make you feel? Like you're boring them and you're not being listened to. Yeah? But that's more acute when you can't see someone, but you can hear them yawning. That weighs heavily. And apologies to Bananarama. Some of you won't know who that is because you're too young, but it ain't what you say, it's the way that you say it. That's basically it. I could sing that for you, but my voice is gone. It's not good. Why is the tone of your voice so important? Because it reflects your attitude. Do you remember? Your attitude affects your behaviour, which affects their attitude, which affects their behaviour. The tone of your voice says everything that you think about the person speaking. Whether you don't like them, you don't want to hear what they've got to say, that you're bored by them, that you've judged them. The tone of your voice is so important, because if there is any inconsistency between the words that you're saying, yeah, I can, yes, I can help you, to, yeah, I can help you. Okay, you're just going to believe the tone of voice. You're not going to believe the words. You know? It's really important. You know, if you say, hello, can I help you? Instead of, hello, can I help you? Same words, different tone. And that really is a hard thing to pull off time and time and time again. It is quite hard, but we have to do it. People remember much more about how they were treated than what the problem was, believe it or not. So even when you don't meet their needs fully the way they wanted to at the very start, if you give them a good experience, a customer service experience, then they'll be happier. Cancer Care UK did a substantial amount of research, and it's being redone as well. And they were looking at why patients were presenting in the UK at end stage. This is pre-COVID. That's sort of stage 2 and 3, and even end stage cancers, so much later in the day than in European countries. Why was that in the UK? So, of course, if you present at end stage, late stage cancers, your prognosis and your treatments aren't going to be so successful. And they'd asked quite a lot of men. The cohort was all men, and I think they had either prostate or stomach cancer. And 40% came up with one particular answer. It's in the general press. I have a link to the BBC site. It's all very depressing. So this is patients who turn up to the first time to see a GP or go straight into hospital, into A&E with late stage cancer. They were asked, why didn't you go earlier? What do you think? What do you think they said? Have a think. I mean, bearing in mind we're talking about primary care. What do you think they said?
I think a lot of people say, I didn't want to bother you. I didn't think it was anything important. I think some people may take that attitude.
That's absolutely, definitely one of the high-ranking responses.
Maybe some people were worried and didn't want to face up to there being something wrong.
Yeah, absolutely. Yeah, disbelieving their symptoms, not really wanting to face it. Yeah,
being scared.
Definitely. Definitely. But one definitely to do with primary care.
Having no symptoms?
Well, that can be an issue, but that wasn't an issue.
So I was thinking in terms of screening and, people find out before.
I was thinking maybe trying the doctor once, not getting through, then not bothering again.
That's exactly it. A little bit more of a flavour to it, though. They said that they called the doctor's surgery and they were put off. They were put off by the tone. That's quite chilling, isn't it? It's quite chilling. Now, the BBC's published this article. I mean, it was some years ago now, but the director of Cancer Care Research said that, he was up in arms about it, and absolutely, and he should be as well, because if that's we know there's a whole load of factors involved in this, but one of them was that the attitudes of the frontline staff in primary care put patients off. And that's a really horrible thing to hear. And he's published it, and he took a big long article out saying people at frontline reception should be trained. Absolutely. I'm not disagreeing with him on that. But as I said at the very start, it's always an anathema to me. I'm absolutely, you know, I can't get my head around the fact that we aren't trained, you know, as we get, if we're offered a job, we should be trained. But there we go, out in the public domain. Doesn't do our reputations any good. So what we need to be doing is doing the best communication skills, putting them all in place together. The more we do it, the easier it is. The more we practice, the easier it is. The more we have our inner resilience, ironclad beetle coming back, not taking things to heart, you know, the Batari circle, the easier it is. We have to use empathetic words and tone. So thoughts, maybe you think, you know, Dr. Jones is the only one that can see you, but honestly, the pharmacist is great. Yeah, perhaps you know, people say to me, you can't use these words, Mairead, because they're very emotional. What's the matter with emotion? What's the matter with we're in the caring profession? What are we, robots? Absolutely not. So long as it's the appropriate tone, an appropriate level, there's nothing the matter with it. Yeah? Nothing the matter with it. The communication skills the GPs learn so that they can get the best consultation is that it's called open versus closed questions. You can ask a question and it could be a yes and no answer. That's not going to get you very far, except of course when you want to say, is it the right leg or is it the left leg? Okay, so those are very yes and no, you know. Is it the right leg? Yes. Okay. There's no pain in your left leg. No. Okay. Those are very closed questions that you really need, right? Those very closed questions came in COVID. When did your symptoms start? When was your last vaccine? Right? All of that. Very clear, very closed. Right? Has it been X amount of days since you had a PCR test or a negative lateral flow or a vaccination? Okay, those are real crunchers. But to get more information and do a really good consultation, you have to use the open question. Tell me more. Again, it's difficult, isn't it? Because I'd love you to be, you know, if you were interested, to come and shadow some of the GPs that I know are just brilliant. Absolutely brilliant. And you know they're brilliant because all the patients want to see those GPs. They don't want to see, oh yeah, oh, is Dr. So-and-so not in? Oh, I like him the best. Because they're really good at what they do.
It's funny, I've done a lot of market research and things. That's exactly the same training that you get in market research.
Really?
Yeah.
So,
and lots of management training, yeah.
It is, isn't it? It's, you know, it's so it's. I don't want to say it's not rocket science, because that means that it's. I'm suggesting it's a bit of piffle. I don't believe it's a bit of piffle at all. There are people out there in management, you know, institutions of management. They're gurus of social awareness and therapy and everything. They're making millions out of this. They sell this type of training because it works. It gets results. It really does. And some people are innately able to latch onto it and go with it. And some, and it's got to be said, and I don't want to malign my colleagues, but some people have been around and in the game far too long for me to undo quite a lot of the negative aspects of how they feel about their job. I can't get them to think in any other way, which is such a shame. And that's all borne out for the fact that, you know, they've been in the job 20 years and they've been trained. They're always going to do this. Well, so what? The patients are always wrong. You know, well, what can you do? That type of attitude. It's quite sad to see, because these people have got loads of experience. But there we go. There we go. Righto. Now, don't think for a moment I've made these up. I've heard every single one of these. every single one. I have a colleague at the moment, absolutely champion young man, delighted and quite honoured to have him with us. He's so enthusiastic. He's a bit like a bouncing bunny. Oh, yeah. Problem with him is he's too enthusiastic. I was like, oh, you know, okay, let's hold your horses. His whole purpose is to help the patients. But because he hasn't done any communication skills training, I know, I'm getting around to it. He's come from other practices. It's come from another 2 practices locally. He doesn't understand that he has to slow things down. He's very good and he wants to help, but he'll hear 2 or 3 sentences or even 2 or 3 words. He's jumped to the end. He goes, I know what you want. And it's that not going through the stair. You don't have to do it exactly in that order, but you can't jump to the end before you've done at least, you know, a lot more listening. And I do have a couple of complaints about him, which is such a shame, and it's knocked him for 6. So we're going to have a conversation. But one of them was about the fact he called somebody a bro, a patient. It wasn't his brother. So no, is all I can say to that. We are professionals, remember? The GPs and nurses don't speak to people like this. If they do, they're wrong. And using, you know, over lazy casual. Now I'm training and I know I've said some things that are lazy and casual, but, you know, I'm amongst friends, you know, I hope. But, you know, we need to smarten our language up. Now, we do use a lot of slang and jargon, but lots of patients now are far more in the know. Obviously, you've got Google. So everybody has a walking dictionary, computer, medical information at the touch of a button. But it's still, because it's important to us if we're going to pursue a career in the primary care, because we need to learn medical terminology. Then we can make it into abbreviations. Then we can say UTI, URT. But we need to know what the words mean first. It's very important when you're coding, when you're managing documents. The difference is that secondary care, you know, you get a specialism and they will have these really complex, convoluted terminology that even the GPs have to work out. But we need to, because they have to be super specific, right? They want to be super specific about which area that they tweaked or didn't tweak or left alone or whatever. We're generalists, and so we can take the general concept and work with that. Obviously, we're as specific as we can be, but that's what we have to do. If we need to be very professional. So we need to remember that when we talk jargon with the patients. This one is, she's picking her kids up from school. I heard. Patient requested a particular doctor, and that was the response. No, you can't have you can't have an appointment then, says the receptionist, because she's picking her kids up from school. I'm like, hey, we don't need to. That's disclosing information that isn't relevant, not appropriate. We have to be professional. I said, you know, you wouldn't particularly relish the fact of your, you know, daily routine being disclosed, so don't do it to the doctors. So yeah, that one unhelpfulness, again, another word that's written time and time again into complaints regarding frontline staff. It's about not taking responsibility. I didn't speak to you. I didn't say the doctor would call you back. That was my colleague. That wasn't me. This is about having protocols and processes. It shouldn't be potluck who you talk to in a practice that's dependent on whether you get a good service or a bad one. Postcode lottery, in practice lottery, it should not depend on who you speak to. There has to be a process. If you have said to a patient, I'm going to take some action, and you take it and you don't write it in the records, then that action didn't happen. And if there's ever any comeback, say, oh, the patient said there was, had to call 3 times to get anything done. Actually, you didn't have to call 3 times to get anything done. I can see that the 3 times you called, my staff took action that was appropriate, and it was secondary care who didn't respond. They have emailed, they have called. But can the patient get through to secondary care? No, they cannot. We can't half the time. So, as I tell my staff, if you take any action on behalf of a patient, then you must record it. Okay? So, taking responsibility. Okay, so one of the things we talk about is golden greetings. This is always, a little bit contentious. Everyone starts to laugh because I say, "Oh, do you have a set greeting that all of you are meant to say?" A bit like John Lewis, a bit like British Gas, a bit like TUI, because I booked a cruise. Brilliant, thank you. It was good. And, this same thing every single time I called up, which was often. And I stayed on the phone for a long time before anybody answered, I can tell you. One time it was 1 hour and 10 minutes, I kid you not. So, and did I compose myself when he answered the phone? Oh, cool, blimey, did I? I had to really put on my Batari box. I was really dressed in the Batari cycle so that I didn't go at the person on the other end of the phone, which would have just got me hung up on. We can use it everywhere. So one of the things is that I say, "Have you got a greeting?" They go, yeah. And then everyone starts laughing because no one says it. I'm like, okay. But it's good to have one set stock phrase that you say all the time. Now, it might seem a little bit, have a nice day. We have to take little steps on the move towards a more professional service, and one of them is the greeting. Hello, good afternoon. How may I help you? Thank you for holding. How may I help you? Okay, that in itself just sets the tone. Otherwise, if you've got a load of people going, yeah, hi, surgery, afternoon. Yeah, we need to be looking towards a better customer service, in my opinion. So these are the professional touches that we'd like. Everybody, I don't call a patient ever by their first name, ever. Ever. There is a distance between myself and the patient. There has to be. We're not mates, we're not friends. We're the professional service and they're coming for assistance. That's my choice. I don't give out my first name generally. Again, because I'm the manager and I think, I'm going to be called more and more often called upon to arbitrate between for complaints, and I want that distance, so I need a bit of professional distance. I'm not unfriendly, but neither am I over friendly. It's down to each practice, really, how they want to play it. But I personally, and I advise all of the teams I work with, that you, unless the patient says, call me Jeff, you call Jeff Mr. Jones. And that's the way it should be. Lots of GPs now, much of the younger crew, are suggesting that the patients can say, oh, is Dr. Sandra in? That's down to them, but I certainly wouldn't say Dr. Sandra will see you. I'd say Dr. Jones will see you. There we go. It's down to each. That's how I think we can maintain or try and, step up to professionalism. Each practice has their own, each partners have their own view on that. I just want to we're at the end, very near the end now. We didn't have our second break, so we're early, which is great. So I told you about cancer research. I want to tell you about this. So this is Hello, my name is. You may have come across it, anybody? You may even see it at the bottom of letters that you get. I know Moorfields Eye Hospital definitely has this on some of its letters. And it's a campaign that was created by the husband of a consultant. Her name was Kate Granger. She was a young woman, I think, was she 32? And she was a consultant in a hospital in Nottingham. I think she was she gastro? No, she was orthopedic, I think. And she flew off 2-week holiday to America. Unfortunately, became extremely ill when she got there and was flown back into the UK with stage 3 cancer of the stomach. And her life flipped over. So she had been a hospital consultant going into hospitals every day to care for patients, into a patient going into hospitals every day to be cared for by consultants. Her life flipped. And her husband, obviously was with her most of for the duration. Of course, why wouldn't he be? And he did say to her, he said, well, Kate, I know she wanted aggressive treatment. There was no way she was going to not accept every treatment going. Why would she? She was very young. He said, I know it's all tough, but you've become really down. What's happening? She goes, well, I've just realised, and I had to take a reflective moment because it's exactly what I've done in the past too. She says, I'm just a condition. I have stopped being a human being. I've stopped being me. Okay, yeah, I'm Mrs. Granger, bed 7, but really what I am, and she's done it herself. She's a hospital consultant. We know it. I've done it myself. I'm CA stage 3 cancer, bed 7, and I know that's exactly. I've stopped. She said I've stopped being me until this man came and rescued her from her doldrums, and this is where the campaign started. She's sitting on her bed with her husband, and up comes a porter, and he rolls the wheelchair towards her, and he said, oh, hello, is that Mrs. Granger? And she said, yes. And he goes, hello, and he showed her about, my name is Brian. Hello, my name is. And I am your porter, and I've been asked to take you to X-ray. I hope you're going to X-ray. Yes, she did. He says, could you take a book, because I might be some time. He said, but I will drop you off. Stay where you are. I have to do another job, but I will come back for you. And if you think I'm not coming, just ask the staff to call the porter's lodge. Off they went. Hello, my name is. Okay. She was Mrs. Granger. He made her feel like a person. There we go. So that campaign is called Hello, my name is. It's a campaign that's being run in hospitals. I know because I've been in hospital recently, and I woke up from an anaesthetic, and there was a person going, oh, hello, Mrs. Roach. My name is Patrick, and I'm your nurse. And I went, oh, hello, Patrick. Conked out again completely, morphined up. And then I woke up again, I don't know when, hours later, and there was, hello, Mrs. Roach. My name is Sandra, and I'm your nurse. And I was like, no, what happened to Patrick? Because that's all I was clearly away with the fairies. Anyway, so hello, my name is. It can get a little bit confusing if you're in a morphine state, but yeah, that's what they're doing in hospitals, and that's something that I think is quite a nice little something small to try and help. So try and remember, we have to have big ears, yeah, active listening, jaw. Offer compromise, be flexible. Batari circle. Sometimes it's called being the parent. Dial a smile. Don't phone a groan. Lovely. Thank you very much. We are a bit early, but that's all good. And I think last thing is, has anybody got any questions whatsoever that you think I haven't answered or would like to raise?
I don't have a question. I just wanted to say thank you so much. It's been so informative.
Thank you. There was a lot to take in, There's a lot to take in. I mean, it was a big rush through private care, but good. Thank you. I'm glad you enjoyed it.
No, very good.
I learned a lot. Thank you very much.
Yes, thank you very much.
Thank you.